Uh, Good evening, Shika.
Hello, sir. Hello.
So,
Hi. Hi, Bhaskar.
hello, sir.
Welcome to the update.
Hello, Dr. Richard.
Hello, Dr. Ramamurthy. This is Mamta here.
Oh, hi, Mamta. Hi, how are you?
I'm good. How are you?
Hello, Dr. Ramamurthy.
Can you hear me clearly?
Yes, sir.
We can hear you.
Mohan,
Yes, madam.
are we live? Mohan?
Yeah, it is live, madam. Live, madam. Yes, madam.
A very good evening and welcome once again to the Cataract update from Netralia, Chennai, India. Is my screen seen? Can anybody tell me? Am I sharing my screen?
Yes, madam.
Yes,
Yeah.
very well.
Your screen is
Yeah.
seen.
Yes. So, I start again. A very good evening and a welcome once again to the Cataract update from Netralia, Chennai, India. And this time we are going to talk about the right intraocular lens. And friends, what's right for one may be wrong for the other. Hence, we need to understand which lens works the best for whom. And to tell us about that, we have some of the best from the world. Let me begin the program with a quick introduction. For those of you who have not attended the previous updates, I am your host for the evening, Dr. Shikha Basi. I am working with Shankar Netralia as a senior consultant in the cataract department. And today, Dr. Mamta Agrawal will be co-hosting the program with me. Dr. Mamta is a senior consultant with Netralia in the uveitis and cornea services, and she's done her fellowship from Proctor Foundation, United States, and she's also organized quite a few conferences, international conferences, uveitis-related meetings. With that, let me introduce the honorable panel, and it's my honor to introduce Dr. D. Ramamurthy, who's the chairman of BI Foundation, and he's been the past president of AIOS and chairman scientific committee for AIOS for a period of 6 years, and he is trained in ophthalmology in some of the best institutes in India. He's done his MBBS from JIPMER, and he has done his ophthalmology from AIMS, and he's been awarded 21 name durations, and he's a very well-known name in India and abroad. Welcome, sir. Welcome to the update. Next, I have Dr. Bhaskar Sreenivasan. Dr. Bhaskar is a senior consultant with us at Netralia, and he is world famous for his work for ocular surface disease. Besides being an excellent cataract and refractive surgeon, he is doing great work. He and his team is doing great work in the field of ocular surface disease, keratoprosthesis. He has numerous publications in peer-reviewed journals, and he's a global ambassador for TFOS. Welcome to the update, Dr. Sreenivasan. Next, I'm very pleased to introduce Dr. Sudarshan Sridharan, Dr. Sudarshan is also a senior consultant in the Department of Uveitis and Ocular Immunology of Shankar Nethralaya. And he is an expert in cataract surgery in uveitic eyes. And besides being an excellent phacosurgeon, he is again very well known for his work in ophthalmic manifestations of HIV in not only in India, but all over the world. He has numerous publications in peer-reviewed journals. Great to have you with us in the panel, Dr. Sridharan. Next we have Dr. Kavita Kalaivani. Dr. Kavita is a senior consultant again with Nethralaya in the Pediatric Ophthalmology and Strabismus Department. And Dr. Kavita excels at managing complex traumatic cataract situations in pediatric cases, and besides being a squint specialist. Welcome to the update, Kavita. With that, I hand over the further program to Dr. Mamta. She'll be introducing our very honorable speaker, Dr. George Olio, to begin the first session. Mamta, over to you.
Thanks, Shikha. That was a good start. We have a great panelists and power-packed speakers in our program. So let me just briefly introduce to our first speaker, Professor Olio, who is well known across the world. Professor Olio is the chairman of ophthalmology, University Miguel Hernández, Alicante, Spain. He's also the founder of Vivior Corporation, Spain, and the George Olio Foundation for the Prevention of Blindness. He's a pioneer in the area of multifocal accommodative and toric IOLs. It's been interest in excimer laser refractive surgery, phakic IOLs, and more recently, corneal regeneration surgery. Professor Olio, he's done more than 50,000 surgeries so far, and he's also authored more than 600 peer-reviewed papers with many chapters and over 100 books. He's also the chair for Academia Ophthalmologica Internationalis and chair of the European Academy of Ophthalmology. He's been the president of ISRS and AAO 2006 to 2008. He's received over 103 international and national awards. We welcome you, Professor Olio, for his presentation on my current intraocular lens options for the refractive cataract surgery, the decision tree, followed by a video presentation, multifocal intraocular lens explantation and substitution by a different multifocal IOL in neuroadaptation failure. We welcome Professor Olio for today's webinar. Shikha, do we have his talk? Yeah.
Yes, yes, yes. I'm going to stop this. Yes. Mohan, you will have to play the talk.
Yes, madam.
Hello, my name is Jorge Alio. I'm very happy to have with you this presentation in which I will deal about which are my current options for the refractive cataract surgery and which is my decision tree in the process of indicating premium IOLs. I'm talking to you from Alicante, Spain, and I'm very happy to share this presentation with you. First, these are my financial disclosures. I have to acknowledge that I work and I'm concerned on several of the companies I will mention along this presentation. First, we have to be aware that today there's a global demand of refractive surgery. And in this global demand, we are requesting many times the help of intraocular lenses in order to accomplish either in cataract cases or in cases in which the indication of refractive lens exchange is clear and good enough for them. Having this in mind, you have to think what Thomas Kuhn mentioned time ago about which is a paradigm. Paradigm is something that we assume to be logically true, but with time we acknowledge that this true is only partially true. So the old paradigm in cataract surgery was that we need to restore vision in aphakia. But now we know, and this is acknowledged, that we are dealing with a totally different environment, in which both because refractive lens exchange is a refractive procedure, or because we're dealing really with cataracts that more and more are demanding a refractive outcome, we're dealing with cataract refractive surgery, which is the new standard, which is the new paradigm. Having this paradigm, every cataract is a refractive surgery. We published in Lancet this paper in which we acknowledge the change in paradigm that affects all lens procedures, and for all lens procedures, modern ophthalmologists have to be aware that they should offer an adequate refractive outcome both for far and for near with the spectacle independence of the patient. Which are my conditions first to get successful outcomes? First, you have to be a very good surgeon. You should do perfect surgery. I have to tell you that I strongly suggest to enter into the tenets of minimal invasive lens surgery meals, which means to do this as little as possible in the benefit of the patient with little invasiveness. Second, we have to have a good indication. We know that indication is different from patient to patient, and we need to acknowledge which is the best one for a given patient depending on the profile. We have to acknowledge that target is emetropia and spectacle independence. So we have to fight to accomplish this goal in every one of our patients with the limitations that sometimes we have in some of the cases. And based on that, we need to choose the adequate intraocular lens, and this adequate lens matches adequately with a good indication. And the purpose of this talk is to offer to you which are my options and the ones that I use more in the selection of the lenses. Finally, you have to acknowledge that we are in a different paradigm, and premium IOS should be very well known by you in order to offer this service to your patients. Presbyopia pseudofocal lenses are at this moment offering monofocal, EDOF, multifocal, either refractive or refractive, and finally accommodative lenses not yet available. Modern premium lenses have a different profile. Let me show to you a little bit more what we are running today into our practice. We have diffractive lenses that all of the trifocal, bifocal lenses have disappeared from the market basically. Then we have refractive lenses. They can be rotational symmetrical. They have quite a lot of light loss, and also they have glare and also halos. This is why sector bifocal have been in the market, and they are very successful, and they are one of my choices. They will have EDOF lenses, which is a very complex issue with a lot of fake news inside. I classify EDOF lenses in type 1, in which we have those lenses in which spherical aberration is corrected. Type 2, in which we have the principle as the way to obtain this EDOF effect. Type 3, in which we have low near vision, and most of them are those that are based on segmental optics, the varifocal optics. Type 4 are hybrid multifocal lenses, in which we have low near vision at diffractive lenses, and these refractive lenses are indeed offering to you just intermediate vision. And then we have optical center modification, which are the new emerging group of lenses like the iHands and the BBT from Alcon, which are now appearing in the market, quite successful, both of them. So how to choose the best one? How can we make a successful indication? For me, I am happy if I can offer to the patient good vision for far. For me, far focus is dominant, and I don't sacrifice far vision in the benefit of near vision. Adequate intermediate, that for me is about 20/30s, enough to have adequate computer and office and domestic tasks. And adequate for near, functional near vision is accomplished when you get J2, which is rather 20-25.8 decimal. This is my definition of success in terms of visual outcomes. Diffractive lenses can accomplish these outcomes, but you have to be aware that depending on the height of these prisms, that makes the decomposition of the light, and how large are the bases, you are going to have more or less near vision and as a consequence, more light dispersion and also more halos and glare. So this is one important issue. There is a limitation that happens in all diffractive lenses, regardless whether they have either high near vision or low near vision. Obviously, the less is the near vision, The less are the halos and glare, but they never disappear. But then, conversely, the near vision is affected. Diffractive multifocal lenses have, as a summary, many advantages, like they offer good vision at all distances, and there is a strong evidence today in favor of them. On the contrary, we have there's always a contact sensitivity loss. We have a quality of vision that might be affected. The more is affected is when they have the largest loss of light with conjunctive function decrease. Most of them are people dependent, especially apodized lenses. Be aware of that, because some patients with prostatic problems or those that have alpha-1 antagonists are going to suffer from pupil dysfunction, and halos and glare are unavoidable in most of them. My choices in March 2021, which is now, are the LISA 8313 and MP franchise, the Rainer 1, the Hanita Intensity, very nice lens, and fine vision. Refractive lenses have a totally different profile, especially those that have segmental optics, like bifocal optics. The pros are they have good vision in all distances. Mix and match is very successful, for instance, making a low near vision arc in the dominant and a high near vision arc in the non-dominant. They are all of them pupil independent. Contact sensitivity is preserved in sectorial bifocal lenses, and the sectorial focal lenses are the best option for refractive models. And as cons, you have that there is peripheral distortion in those lenses in which the powers are more than 1.5 to 2. So this is something that you have to acknowledge. They have dysphotopsia, but not when they have up to 1.5 near vision arc in which they are free from all these symptoms. My choices now are the Acunis Vario with 1.5 and the Acunis Vario Max +3. The negative effect in multifocal lenses is considering the photic phenomenon. Photic phenomenon is much more prominent in diffractive lenses than in refractive, but in refractive, when you have a near vision arc of +3, you always have this photopsis as well, not when you have only 1.5. Be aware of this because halos, glare, and starburst are going to be present depending on the amount of near vision arc that you are going to offer. The EDOF concept today has to be taken into consideration. EDOF concept comes from the defocus score. It's the elongation of the far focus into the intermediate, and in doing that, you gain spectral independence for intermediate vision, but not for near vision that much. This is important because you have to know that these lenses are weak for near vision purposes. This is the way in which you get in the monofocal and the EDOF lenses this EDOF effect, which indeed deteriorates the quality of the retinal image because this focus is not that precise like in a monofocal, but obviously there is no so much superimposition images because you don't have different foci in the same place. You have always a degradation in quality of vision, and you have to think that in order to match adequately EDOF lenses based, especially in the change in your manipulation, in the spherical aberration, you have to work knowing which is the sphericity of the patient's cornea, and this sphericity should be taken into account when selecting the spherical correcting intraocular lenses that are offered in type 1 EDOF lenses. Please read this original editorial that I wrote in a specific journal of ophthalmology. You have here the reference in order to know and to differentiate which are fake news and good news with EDOF lenses. Remember, we have 5 types based on the spherical aberration, based on pinhole principle. These 2 are the traditional EDOF lenses. The first ones, those that are based on its changes in spherical aberration, have been totally abandoned by me because poor quality of vision and insufficient near vision outcomes. The pinhole principle can be used in regular corneas, but remember, whatever they say, they are restricting the peripheral visual field, and the visual field is limited in 60 degrees visual field test. You can acknowledge that you have a decrease in peripheral visual field. This is why I seldomly use them. No poor near vision are the bifocal lenses up to 1.5. Very good lenses, you accomplish complete spectral independence for intermediate and a lot of help for near vision, not at the cost of providing any type of negative dysphotopsia. Hybrid lenses are abandoned by me because they are diffractive, they cause halos and glare, they are very bad for near, and those, like the Symphony, have been, in my opinion, totally overcome by other models, even from the same company. And then they have what I call the monofocal plus. They are lenses that have a manipulation in the central part of the optic increasing the power in the 1 millimeter or making an elongated wavelength, which is a mechanism by which both of them are working in the benefit of near vision. They're working very well. They don't cause dysphotopsia, and they are a good option. They are becoming an emerging group of lenses. So, having this in mind, remember, not all EDOF lenses are really EDOF. They are only EDOF those that have an elongation in the far focus into intermediate, and this EDOF, if it is only present in pure fashion in some of the types of lenses, which are those that are type 1, 2, 3, 4, 5, but those that are especially near vision at refractive are not to be considered that much EDOF, but low power near vision diffractive lenses. This is why the American Academy of Ophthalmology states that EDOF lenses are only valuable and acknowledged to provide spectacle independence for intermediate vision. So the good thing of EDOF lenses is that they provide good intermediate vision, less halos and less glare in most of the cases, not in all, less patient satisfaction, because near vision is not accomplished. They have almost a monofocal behavior, but you have to think that this is happening only when you deal with refractive models, and the Vivior and from Alcon, eye-hands are the best of this group. On the contrary, they provide not that good near vision, and even bad near vision. Quality of vision is especially bad in type 1 lenses, though that are based in the spherical aberration manipulation that not only have a poor outcome for near, but they give bad quality of vision to the patient, and the peripheral visual field is affected in the type 2 model. Remember this because it is important. My choices of EDOF lenses are the eye-hands, Johnson & Johnson Vivior from Alcon, and the Acunex from Teleon. This is type 3 EDOF. So I've used 2 type 5 eye-hands and Vivior, and 1 type 3, which is the Acunex Teleon. If you want to read more, you can go to this paper published in the Asia Pacific Journal of Ophthalmology dealing about EDOF lenses, what is true and what is not true. This will clarify a lot your concepts in this regard. In summary, EDOF lenses are good in order to provide some help for intermediate vision, but they are going to have some advantages and disadvantages. They have really not that much night vision problems. Patients are not left spectacle independent for near. They are not designed for the near vision lenses. They are designed to be intermediate vision lenses. So you have to think about that before indicating the lenses, because that depends on the profile of your patient. Monofocal lenses have been used in terms of monovision. Monovision uses a near metropia in the dominant and a 1.5 about myopia residual in the non-dominant. This is a very interesting issue. Not all patients are accepting this type of concept, and you have to consider that there is a model now that is becoming available in the market, which is the Reiner MBA, in which you have not only a disparity in the refractive outcome for based on the induction of small amounts of myopia in the non-dominant eye, but it's different and asymmetrical spherical aberration in the benefit of near vision. This lens, according to the preliminary results that I have, is working well, and this, in my opinion, an excellent option as a monofocal lens, providing intermediate and near vision spectacle independence. Think on that, this is still an option. But do not use massively, as many patients will not understand monovision. So finally, how I am selecting the IOS of choice. You have to think that this is a function of the eye and function of the brain. The brain is what is going to be never adapting to what is the image that you provide in the eye. The human eye is not a multifocal one. Mother Nature has not provided with a multifocal optical system. So this is why neuroadaptation is essential, and EDOF principle is easier for the brain, but it's not always successful because of the poor quality of the image. So you have to define what is best, what is good and what is not that good, based on visual outcomes, on contraceptive function, and the focus score. Obviously, cost is an issue as well. And let me go through these important concepts now. This is quality of retinal image. You will soon have available a paper that we have published with this information, in which we are defining which are the best lenses in terms of quality of retinal image. You can see that the spherical monofocal lenses are the best quality of image, but you can see some multifocal, trifocal, especially the lizard tree from size, is providing almost an identical quality of retinal image that monofocal, which is remarkable. Other lenses like the Mini Well, which is an IDOF type 1, gives a very poor quality of retinal image. Now you have an explanation why these lenses work so poorly in our cases. Accommodative lenses are like monofocal. This is the Lumina lens, which is an excellent lens that will be available soon because they obtain the CE mark. We have investigated this lens for almost 12 years. Then multifocal diffractive and refractive have some dysfunction in the retinal quality of image, but it's acceptable, while some others have, like the iHands, very good quality of retinal image, even that they are never like a monofocal. Look here as an example, how is a monofocal, the SA60, how is the Lisa tree, and the Oculus MF30, which is a segmental varifocal lens. Look that in the best is for the monofocal, not that different, and you can see the convoluted image in the downside of the slide as the trifocal, and this very good lens varifocal is giving a very nice retinal quality of image, even that is not as perfect as the others. But on the contrary, look here on the IDOF type 1, the Mini Well, how poor is the quality of retinal image when you compare with a monofocal. Here we are comparing again the same lenses, and you can see here how the quality of retinal image is definitely one important reason to choose one versus the other. This is again the monofocal versus the IDOF Mini Well at 3 millimeters. And this is just as a summary, monofocal, multifocal IOL, and IDOF. Look here how the quality of the multifocal diffractive have increased and how the IDOF lenses type 1 are not those that you should choose for the patients. Just look at the convoluted image for 3 millimeters. Even in 3 millimeters is very poor. Imagine that you go to 6 millimeters, will be awful in night vision. Low mesopic contrastivity is what matters. Different lenses have different type of profiles, and these different type of profiles have different types of contrast sensitivity, and that are especially critical when you are dealing with low mesopic conditions. Go to this paper in which we publish the low mesopic contrast sensitivity function for different intraocular lenses. Choose those that have less loss of contrast sensitivity function. The best are obviously the monofocals, followed by the trifocal lens, followed by the varifocal lens, especially the M+1.5, which is the lentis comfort, and then the others are behind. And the more the near vision are, and the more diffractive models, the less is the quality of the contrast sensitivity function in high spatial frequencies, and that makes a difference between one model and other diffractive lenses. And this is a quality issue that you have to take into consideration. As you see, we have different type of profiles. Every lens has a different contrast sensitivity function. If you want to read this, go to this paper published in European Journal of Ophthalmology, in which we publish the different contrast functions of different types of multifocal lenses that you have to take into consideration when making your choice for one or the other. Then you have to match the focus curves. The focus curves, here you have the one of an emmetropic normal patient of 30 years, and then on the right you have a normal 40 years also with good intermediate vision, not that good near vision. You have to be in between, and those that are bifocal have different type of neuroadaptation. So remember, neuroadaptation is a process in which the patient has to base this satisfaction. Satisfaction is better when you facilitate to the patient the capability to understand what is the message that the lens is providing in terms of quality of retinal image, and also how many images are provided. This is why the focus curve is a critical issue in selecting your lens. Here you have different focus curves of the different lenses. You have to match your patients with them. You have to think that those focus curves that are more like a plateau are more physiological and easier for neuroadaptation. This is why IDOF lenses with good quality of retinal image offer a profile that is nearby a pre-presbyopic patient, and intermediate vision will be good, and the neuroadaptation will be almost zero with minimal or no photophenomenon. You can read the different types of the focus curve of different lenses in this paper that we published in the European Journal of Ophthalmology about this issue. Be aware that the focus curve is a critical issue in your choice. You need to mesopic contrast sensitivity in the choice that you make of an intraocular lens, premium lens for your patients. Here you have how different is a bifocal lens from a regular lens. this lens, being bifocal, has a neural adaptation that is more complicated and will have more halos and glare. Here you have how some lenses that are offered as EDOF, they are not EDOF because they have a bimodal profile. This bimodal profile makes halos and glare and neural adaptation to be less successful. So let me give your last remarks about my personal approach to premium lenses. You have to choose the best that are those that are adapted to the patient's profile. And you have to define that by the patient needs, personality, and moreover, you have to develop realistic expectations in your patient by your chair time. Second, you have to confirm that there are no comorbidities that might affect the visual outcome and especially contraceptive function. They are not good candidates. Those that have low contraceptive function, like elderly people over 80, or patients with different type of disease like glaucoma, they will never have a good neuroadaptation. Be sure that you are going to confirm in a realistic way the expectations that you have raised in your patient. Finally, you have to select the lens that with the focus score is better adjusted to the patient's profile and have in those that are with this capability because of the focus score, choose those that have the best quality of retinal image and the less loss of contrasensitivity or normal contrasensitive function following the implantation, like those that are based on sectorial bifocal optics. So matching lenses with patients is the goal. My regular ones at this moment from the diffractive world are the 339 MP, the Rainer one, high intensity and high vision. I am implanted about 60% to 70% of my patients with multifocal lenses, and half of my patients are implanted with these models. Refractive lenses are very much used by me, and these are because the 1.5, the lens comfort is a very good lens with no halos, no glare, and no neuroadaptation. I use the Oculus Varium from Teleon, which is similar to the Oculus Comfort, and the Oculus M+3, which is used in a blended fashion. I seldomly use the M+3 on bilateral basis because it is photopsia and some peripheral distortion happens in these patients. I'm using them in about 30% of the patients that are implanted with mid lenses. And these other lenses are implanted by me in about 20% of my cases now, in which I use premium lenses, in which my preferences are for the VVT from Alcon iHands. I use also the plus 1.5, but I have classified this in this chart in the refractive, but these lenses both in the refractive and EDOF groups. So they are my choices today in my practice. And remember, from 60 to 70% of my patients are being indicated by me with premium lenses. You can read most of what I have explained to you in this book that I published with Joseph Piquel 2 years ago in the second edition, Multifocal Intraocular Lenses. They are under practice. And you can have this course, which is an online university certified course of 275 hours of learning activities on multimedia based on refractive lens and cornea surgery. Those that are in the wish and the attitude to learn more, please go to this course. It's fully online, fully in English. Most of you, especially junior ophthalmologists, will find it extremely interesting and useful for your practice. And I want to thank you from Alicante very much for this kind invitation and the honor to be with you during this day. Thank you very much.
Thank you, Professor, for an excellent talk.
Thank you.
So should we
Any
continue
question?
video presentation?
Good.
Yeah, so we will continue with the video presentation and then we'll take the questions.
Yeah.
So probably before the video is presented, Professor Olio can tell us about the video.
He's muted.
This case is dealing with a case in which neuroadaptation failure led to patient dissatisfaction. We have been dealing with different methods to treat patient dissatisfaction, and what I'm going to show to you is the one that we have found most adequate and most successful, which is to exchange the multifocal lens that has been implanted and is failing by a different type of intraocular lens, multifocal with a different optical technology. In other words, if you have a neuroadaptation failure in a patient with a restore, for instance, I change by a refractive model. So diffractive cases are exchanged by refractive. And you have a refractive failure, a refractive lens failure multifocal, then it is by a diffractive. This was based on preliminary studies that have been reported about the activation of different areas of the brain, by different types of multifocality, and led us to try this method as an alternative to substitute the lens, the multifocal, by a monofocal lens. The consequence, and we are reporting this year in the American Academy of Ophthalmology, this study, is that those cases implanted with a multifocal IOL exchange with a different optical profile are better and more satisfied than those that are exchanged by a monofocal lens, which is remarkable. And I know that it sounds bizarre and unusual to change a failed multifocal by a different multifocal, but believe me, this is the best way to handle these cases. What I'm going to show to you is how we change one lens that was an EDOF lens by a refractive lens because neuroadaptation failure. And this is what is the subject of this presentation that we can discuss later on.
Sure. Mohan, let's watch the video. Professor's way of lens exchange in case you have a problem with a premium IOL.
Okay, may I have a comment, Sika?
Sure.
So in this video, I have been showing to you the bilateral substitution. So if the first eye does well, I do the second eye in the same setting. And you have seen that in the first case, as far as the patient has been waiting for 8 months for the exchange, because it's something that we never do before 6 months, if possible, you saw that this lens caused very important additions in the capsular bag that made the explantation to be difficult. This is very important because this is not happening when you use a capsular tension ring. I always use capsular tension ring in using my multifocal lenses because these maneuvers are very much facilitated and speed up, and you can explant these lenses even 1 or 2 years after the surgery, if fail, as far as you have used a CTR. In the second eye, this patient had a much more straightforward explantation and substitution. And as in this case, I choose the lens, the Oculentis 1.5 and 3, because I use blended refractive asymmetrical lenses used with very successful outcomes, and the patient was totally solved. The lesson to learn here is, number one, be aware that some EDOF lenses are not that good. This lens is awful, and sorry to tell you, because it provides a very bad quality of retinal image because it's over manipulating the spherical aberration. This is the first issue. Second, if you want not to run any risk about exchanging the lens, use a CTR. I always use a CTR in my premium lenses for this reason. And number three, be aware that in these cases, you have first to use a spatula to depress the lens to detach the furonectin additions that the lens has to the posterior capsule. Then you have to use a lot of cohesive viscoelastic in order to dissect inside the capsular bag the haptics. And once that you see the lens mobile, then you can extract it. You have to be very careful not to detach the sonulars, because sometimes, as in the first eye that you saw in this video, you have difficulties, and these cases, sometimes you have even to cut the haptic and to leave the haptic there. Other issues that I prefer always to use, if I have been using plate haptics, another plate haptic lens, or if I have been using a C-loop, another C-loop, because the imprint that the previous lens has made in the capsular bag and the contraction makes room for the lens in a much better way. So this is the way in which I handle neuroadaptation failure. And there are 2 papers coming now soon on this topic that in my hands is working very well in these unfortunate cases. Thank you very much for this opportunity to comment the video.
That was wonderful. We have Dr. Ramamurthy also with us. Sir, would you like to make any comments on? We'll begin with the video first, since the discussion is on about the video. We'll go to the session-related questions later.
A great presentation, Dr. Alio, and enjoyed the presentation as well as the video. But it requires a lot of guts to replace one multifocal with the other, because most of these multifocals, of course, the reason for the dissatisfaction has also got to be taken into account. If it is an inappropriate refractive outcome, if it's a biometry problem, the patient is not happy with the near vision, maybe you want to exchange a EDOF lens with a trifocal, those things are all right. If it's the quality of vision, dysphotopsia, we all know that all these multifocal intraocular lenses by vision at all distances using the currency of contrast. And when the patient is not adapting to one particular multifocal intraocular lens, I believe, of course, you see that a couple of studies are coming out. I trust there should be a lot of new information in that. But as of now, I would believe that if at all I'm pushed to exchanging a multifocal intraocular lens, which is very rarely, then I would go for a monofocal intraocular lens. And usually what I find is that I do find patients who are not quite happy with their multifocal intraocular lenses. Most often, rather than being it a major complaint, it's an observation that these patients make. And as you rightly said, I also wait for a period of 6 to 8 months. I have a simple -2 diopter glasses with me. Whenever these patients come to my clinic, I allow them to read comfortably. They say that they are suffering from some amount of dysphotopsia. I slip in these -2 diopter glasses and then ask them to read. I tell them that this is what you gained out of this multifocal. Of course, you paid a small price by way of your night vision difficulties. Do you want me to explant these lenses? Most often, these patients opt not to go for an explantation. So they're willing to live with a certain amount of compromise as far as the quality of vision is concerned. But I think it's a very interesting concept to exchange one multifocal with another one.
Thank you, Ramamurthy.
And
You are-
both with
Yeah, you are a very good friend and very good surgeon. And I know that this is challenging, and I know that it's challenging your imagination. It's not conventional at all, you know. But I have to tell you that we have over 50 cases already, and we have compared with the monofocal exchange. And the patients are not happy with the monofocal because they get right from the distortion, they get right from the contact sensitivity, but finally they are using glasses for near. And the issue is that you can deal with a multifocal lens or different technology because the nerve adaptation is different for diffractive than for refractive. The MRI studies have demonstrated that activate different areas of the brain, and refractive lenses do not cause significant contact sensitivity loss. This is why these patients with waxy vision or inadequate vision, they are happy with refractive. And some patients are not happy with the distortion caused by the refractive lenses. This is why they are happy with the diffractive. So believe me, there is science in this approach. I know it's not conventional, but I do believe, in my hands, it's working very well. That is my recommendation for you, to provide a second option to these patients that have been failing because the previous implanted lens has not been happy. Of course, you have to remember, number one reason of patient dissatisfaction following a multifocal lens is residual refractive error. And I'm dealing always with residual refractive errors with glasses. If with glasses the patients are happy, go for refractive surgery, and that's all. If the patients are not happy with glasses, then you have to make this approach in order to get right from the patient. Thank you.
I think that wraps it up properly. We'll go to the session questions now. I'll share the screen for that. Okay. Is my screen seen? Am I sharing my screen?
Yeah, very.
Yes, yes.
Good, very good.
Yes. So we'll begin with the first session questions, and Mr. Hanuman from India, he wants to know if somebody is starting as a phaco surgeon, he's a beginner, then what should be his advice about the intraocular lens choice to the patients he is operating on? What all he can offer to his patients if he's starting as a beginner? So we can stop sharing. And
This is a very
so basically, if we can put it in a different way, is refractive cataract surgery right from the word go? You know, you've learned phaco and you become a refractive cataract surgeon.
Yeah.
What all he can for a beginner,
My advice for beginners is to run the minimal risk. I have had excellent outcomes with the rotational asymmetrical lenses, with the varifocal lenses. The M plus 1.5 gives intermediate and near vision, is a refractive base EDOF, and definitely is my choice for beginners. If you want to be a little bit more in near vision, then you can use the blended vision with the varifocal lenses, using the M plus 5, 1.5 in the dominant, the plus 3 in the non-dominant. And this is about the refractive lenses, refractive technologies. Use a causal attention read always. And then if you want to go, because these lenses are not available for you at this moment, my recommendation is to run for the new monofocal plus lenses, which is a type 5 EDOF lenses that of my classification. Use the iHands. iHands will give to you good intermediate vision, not that good near, but you can play with monovision, and then you really have a good chance to live a happy patient with no dysphotopsia. And the VVT from Alcon is giving very good results in my hands. Near vision is not the best, but it's not bad either. And this lens is not tolerant that much to monovision. So if you want to have rotational asymmetrical lens varifocal, use them. If not, try to go to the EDOF type 5, iHands number 1, VVT, second choice, because it's more expensive. With iHands, you can try monovision, leaving at -1 in non-dominant, very happy patients. With the VVT, you have to target episode.
Okay. Any other comments from the panel?
No, I think, Jorge, you're right. You want to go for simple things to start with that you know are very, very unlikely to cause major problems with the patient. But the other issue also is to find out what the patient wants and expects, because there's no point putting a lens in that is not going to meet up with their potential expectations. And I believe that most of the problems that people have post-operatively have developed because they've not spoken to their patients properly before the surgery, and that they have a very good understanding of what is actually being put in front of them when they have their surgery. And most of the time, if you've got a good understanding by your patient as to what you're going to be doing, it's very unlikely actually that they will have problems. I mean, even things like glare and halos, I would tell all my patients in advance, if they're having a diffractive lens, that they will get glare and halos because it's a function of the design of the lens. And because they know they're going to get it, they actually adapt to it much more quickly, and you have very few problems that way.
And Bhaskar, would you like to add something?
So just coming to the point of a beginner cataract surgeon, that was the question. So if you're starting off your cataract surgeries and your phaco surgeries, and the most important thing is to be sure about your refractive astigmatism. So you need to look at cataract surgery, not just to be able to finish the cataract surgery and put a lens inside. It has to be synced in that you need to give refractive endpoint, which is neutral to the patient. Again, this neutral is something which you need to discuss with the patient, what the patient wants. If it's a patient who is basically more at home, she's a wheelchair driven patient, then you might probably give them a little bit of a near, like a monovision kind of a thing, because you don't have to aim for 6/6, because that patient is not probably going to have a plano 6/6 vision requirement. Even when you're not offering a multifocal lenses to the patient for whatever reason, maybe dry eye, maybe diabetic retinopathy, it sometimes is very important to make them understand why you're not offering a multifocal lenses, because post-surgery, they come and they compare their vision with their colleagues who are able to read without glasses, and they become unhappy. So it's very easy to tell it upfront that you are not a candidate for some of these premium lenses because of 1, 2, 3 factors. And for you, we would probably go for a monofocal lens, or at this point of time, the expanded monofocal in terms of the eye hands or the vivity seems to be a trade-off between a monofocal and a multifocal, giving a reasonable amount of intermediate vision, which is what we require these days with more of our cell phone and computer usage as such.
Dr. Arnia, you wanted to make a comment?
Yeah. We can get back to the questions for beginners. So you need to have your confidence in yourself and confident in your patients. So this is the most important that you think about, not the technology. It's not about you put the fancy technology for the patient in this stage as a beginner, but you need to have a confidence in yourself. This is very important. Because if you put a high technology in a wrong patient, you are going to lose the confidence for the patient and for yourself. And this is very important in the early stages in the career. The second, you should do a perfect phaco, because the premium surgeons need a perfect phaco with no problem at all. Because you need a size of the rexus, well-centered, no problem in the posterior capsule, no zonulosis. This is very important before you choose the premium. Then, as Dr. Packard and Dr. Aylio said, the eye hands giving the best when you do a little bit monofocal in the eye. So it makes the beginning, the patient will going to be happy rather than a trifocal from the beginning. This is my opinion.
The next set of questions there was all about how do you decide which technology, which lens technology for presbyopia correction will fit which patient. I had shown the slide previously. The remaining 6 questions in the session were, around this, that how do you decide as a patient walks in, it's to the panel and the speakers, everybody, any single thing, the patient walks in, every patient, whatever chair time is given, how do you decide that, which technology, lens technology goes? Any quick tips from the such expert faculty that we have, that what is your, everybody must be having some few things in the out patient that I'm going to give for this patient. There is so much to offer these days in terms of presbyopia correction. So for how do you select your patient that this technology is going to fit this patient? Any quick clues about that?
Okay, first I explore, this is the subject of my presentation. So it's the big
Yes.
Already.
Take the patient lifestyle, and how is the personality of the patient? How intolerant is the patient? If the patient is intolerant, or you presume that the patient is going to be a problematic one, go to the options that are more conservative, which are the type 5 EDOF, enhanced and beauty with some monovision, or go to the rotational symmetrical, the ocular length is 1.5. With these choices, you will not fail in these patients, because if you explain the patient that near vision will be sometimes with glasses, and the patient says that's what you can offer to them. If the patient has a lifestyle that is normal, that means it's a urban patient with a normal style in which office is the main dedication, you need to provide near vision. These patients are never happy if you don't provide near vision. And then my choice, number one, is the size, trifocal. Trifocal size is an excellent lens. It's the one that has shown in our hands to give the best quality of retinal image analyzed by pyramidal barometry in the human eye. It's not ex vivo. And similar to these lenses, but not that good, are the fine vision and the Reiner one. The reason why they are not that good is because the retinal quality of image is less good, and they take part of contrast sensitivity in the low mesopic range. And then you have a new lens, which is the Hanita, which is a lens from Israel, which is a very good surprise, because the contrast sensitivity is untouched, in spite that it's diffractive, and it's very good intermediate. This is because the manipulation of light in the prism. So, as a summary, if you find a difficult case because of the personality, or because the patient is really not happy to have any photic phenomena, go to the very conservative ones, enhanced VVT or M plus 1.5. You want to have normal behavior patient, and you want to provide a very good assistance, then you have to give probably a good option with the diffractive models. And you want a patient that really needs to read a lot, and the patients are lawyers or doctors are good examples, you need to provide near vision. And again, the size is my favorite lens at this very moment.
Can I just add something which we haven't really mentioned so far, which is a product which will be available soon, called Vivior. And I'm sure Jorge is aware of this. And this is a clever device that you fit onto a pair of spectacle frames, and it actually monitors what the vision usage is in terms of different foci for an individual patient. Because often patients will tell you a story about what they say their visual requirements are, but actually when you put a device like this on them, you find that it's something completely different, and that they actually may be spending very little time at reading. Most of their activities are intermediate, or the opposite. That when they say to you they're maybe just reading a magazine now and then, are actually spending a lot of time doing that. So this will also help you to decide what is the lens that you need, whether you're going to concentrate on the intermediate vision or whether you need to concentrate on the near vision.
Richard, I agree with you. The problem is that these devices, the simulators, give to you a very short perspective on the patient. Many patients need 1 week to really get the benefit, and they are kind of misled sometimes, not always, misled by the simulator's outcome. So
this isn't a simulator, though. This is something that they actually wear and monitors what they do. It's not quite the same thing as a simulator.
Okay, yeah. But whatever can help to you to build up your decision, and the patient can test a little bit what is going to happen is fine.
Yeah, absolutely.
Just I'm going to highlight that the ocular surface disease is very important when you choose a premium IOL. Never ignore this, because you can do a perfect operation with a perfect result, but the patient is unhappy simply because he has already ocular surface disease. So any patient with grade, I think, moderate to severe, I don't recommend premium IOLs at all, because whatever you are going to treat the ocular surface disease, the patient will not going to be happy at all.
And Mamta, would you like to take the next session? Next set of questions?
You're muted, Monta.
You're muted. Mamta, you'll have to unmute yourself.
Sorry. So as we discuss these things, we are all talking about the normal eyes with no comorbid conditions. So there were some questions from the audience. What if the patient has a white cataract? We still can offer them. So the second question was, what about the traumatic cataract? What is the panel's point of view in these two conditions? If a patient has a total intumescent cataract, can we still advise a premium IOL? And how about these traumatic cataracts? So what is the, anyone who wants to give their opinions? It's an open.
These are the situations, basically tricky situations, the complicated cataract, uveitic eyes, then in children, and if you've had a PCR in a patient who's had already. So these situations we can all in one go, discuss in the next set of panel discussion.
So let's start from the total cataracts and traumatic cataracts. So what is the panel's point of view in these two scenarios?
Well, I think you can offer a patient a multifocal with a white cataract. I mean, that's not the issue. The issue is, does the surgery go fine? If the surgery goes fine, you put in the multifocal lens. I mean, what's the problem? A traumatic cataract, I think, is a completely different issue, because the big problem with particularly trifocal lenses is you don't want decentration.
True.
And if you get decentration, then you're going to have a miserable patient. So you've got to assess what's actually happening in the eye. If the bag is intact, if the capsulotomy is still central, then yes, of course, you can, in a traumatic eye, you can put in a multifocal. But I certainly think it's unlikely, if there's any significant trauma to the eye, that you will be able to.
Yeah, for me, trauma, as far as the macula is normal, is for a multifocal. The problem is that you have young people in favor of the outcome, the good neuroadaptation, but on the contrary, you have the problem of asymmetrical quality of vision. So what I usually use in this case is refractive lenses. Refractive lenses do quite well, even that they have some peripheral distortion if you are using the M+3. This distortion is very well managed by young people and is my number one choice, because there is no conductivity loss, and in my hands is what are provided with a better outcomes. In pediatric cataract is different. Pediatric cataracts, I prefer diffractive lenses because they are much more universal and they can be explanted better because the models are usually thinner, and you can play with this lens in the future in a better way, and always with a CTR. And in white cataracts, I am guided by the second eye. The second eye has ocular degeneration or has any comorbidity. I don't use multifocals because I cannot predict the outcome. If the other eye is totally normal, or I can see the fundus, then I can really anticipate to the patient that even that we don't have a control of the visual outcome, because might be the patient has a comorbidity that we ignore, a multifocals could be implanted. In these cases, I prefer the EDOF type 5, again, the VVT or the eye-hands, because as far as they are almost monofocals, they leave the patient with acceptable to very good outcomes always, and you run less risk if any comorbidity happens.
That's a good one. So we gather the opinion that probably EDOF type 5 is the choice in these lenses. So how about eyes which have chronic uveitis? So would you really think, or eye hands, EDOF type 5 is still an option in uveitic eyes, or we still do not recommend these eyes?
In uveitic eyes, I try to use monofocals because these patients are with too many problems to add something else. You cannot predict the patient will end in macular edema, the patient has a planitis, or if finally the patient will have any problem with the diameter of the pupil, because pupil plays a role in pupil-dependent lenses. So my choice is for monofocals. It's one of the very good chances that monofocals have a good indication today.
Yeah. How about Fuchs uveitis, Professor Olio, where we don't really have other problems in the macula, which we normally know that they don't develop macular edema. It's basically the vitreous floaters, debris, and sometimes the intraocular lens deposits because of the recurrence inflammation. Would you think of EDOF in Fuchs uveitis or no? Because they're all young patients. And we
Yeah,
don't
you
feel
know,
immediate vision may be a good option. But how about in those cases?
well, that number one, Fuchs is not a uveitis. It's a sympathetic disease, you know. There is no problem in implanting a lens, but I usually use pupil-independent lenses, because these patients, even that they have not a chronic problem because they are a dystrophic sympathetic denervation problem, and they are not really inflammation. The real thing is that the pupil is not managed in the same way. These patients usually have larger pupils and dyschorhea, and this is because of the use of stress, and I prefer to use, in these very cases, multifocals that are not pupil dependent. So get right from all the apodized lenses, don't use apodized lenses. You can use the varifocal lenses because they are pupil independent up to 6 millimeters, and any of the models that have at this moment quite good performance without any given pupil diameter are doing well. In these cases, the type 5 not working well because type 5, especially the eye-hands, works according to the pupil size. So the best outcomes with the eye-hands are in those patients in which meiosis is accomplished for near vision. And these patients, you cannot predict this at all, but rather that they will have intermediate to large pupils, and these cases are better for diffractive, non-pupil dependent, like the size trifocal. Size trifocal is my choice.
I have Dr. Ramurthy's comments.
Shika, I have a
Sir, you're muted.
Yeah, I mean, am I audible now?
Yes, sir. Yes, you're audible.
Okay, thank you. I know that I'm speaking to a set of UVA experts, so I'm a little wary of that. And as far as the choice of multifocals in uveitis patients is concerned, it entirely depends on the stage of the disease. If it's a past history of uveitis, the eye has been extremely quiet without any inflammation occurring in the recent past, without the need for any steroids. And the macula is pristine, there's no glaucoma, the cornea is healthy. And even if it's a unilateral uveitis and cataract, and if I can get a round pupil, I would not really deny the patient the benefit of a multifocal intraocular lens. I think these patients would do just as well as the other patients with cataract. But obviously, if there is any kind of a compromise and you feel that there could be, in the postoperative period could be quite stormy, I would rather avoid multifocal intraocular lenses in these cases. And as regards the total cataracts and traumatic cataracts, I think it will entirely depend upon the way the course of the surgery proceeds. You know, very often total cataracts is quite easy to handle. Of course, it's more the counseling, telling the patient that it's possible that we promise you a multifocal intraocular lens, but then because the surgery did not go as planned, we shift over to a different type of a lens. Traumatic cataract is a different cup of tea, and if there's not adequate zonal support, if the lens itself dangling, obviously we would rather go for a monofocal intraocular lens. But otherwise, very often these traumatic cataracts are unilateral, and I have put in unilateral multifocal intraocular lenses with reasonably good results. And today it's essentially trifocal intraocular lenses, which are my choice. And regarding pediatric cataracts up to the age of about 6 to 7, I keep away from that. But beyond the age of 6 or 7, I go ahead and implant trifocal and multifocal intraocular lenses. And I believe that there is a certain need for the myopic outcome will be there. But this is something that we can handle a little later on after the age of 18 using a laser vision correction. I'm rather wary of prescribing bifocal lenses to my patients who have a developmental cataract.
Kavita, would you like to make a comment about the pediatric choice of option with pediatric cases?
Yeah, I slightly differ from Ramamurthy sir about the age at which multifocal lenses are offered. Probably above 14 and above, we can consider, even though we still are hesitant, because myopic shift theoretically still continues till the age of 16 or 18, especially after you do a cataract surgery in children. So I would not relax to as young as 7-year-olds, but yes, options are being tried about multifocal IOLs in children. So we still stick to unifocal lens since predictability is not very easy at that age. Second thing, back to the trauma, when there is a corneal scar, is there a role of toric IOLs in traumatic corneal scars to manage the astigmatism?
I think, Kavita, we have this in the next session, this question about trauma and toric.
In Dr. Armia's talk, after Dr. Armia's talk, we shall be
Armia,
taking
you want to
toric.
add that? We'll take a quick here and then go to the next
I
session.
think we need SKG ma'am's comments. We have an expert, the deputy director of our uveitis department, about her comment. Without her comments, it's incomplete. Ma'am, your opinion about multifocals options in uveitic eyes?
Yeah, multifocal options in uveitic eyes, Shika, I would be very wary of using them, because at the moment the patient may appear to do well, but a few years down the line, you never know what is the number of uveitic attacks that he's going to get, what is going to be the status of the macula maybe 5-6 years down the line. So I don't use multifocals in very bad or chronic uveitic eyes. But as Mamta said, maybe Fuchs, we could still maybe try in Fuchs uveitis, but again, you have to use pupil independent designs of multifocal lenses, not those which depend on the pupil size.
I want to add two things.
Professor Amia, you want to add something?
Just to add to the previous words, in traumatic and white cataract, if we are going to use a multifocal IOLs, usually I put a modified Sione ring with 2 holes, because in these cases, the decentration can happen anytime, especially the capsular phimosis. So this will let me easily suture the modified CTR in the sclera at any time, rather than to change the IOL. And in pediatric cataract, it depends on either it's a unilateral or bilateral. If it's unilateral, I'm going to put the multifocal at any age, because usually there is no increase in the size of the eye a lot. But if it's bilateral cataract, I will going to wait till the age of 14, 15, because this age it is a stabilization of the progress, and we can use the multifocal in this age with perfect results in the rest of the life.
We have another question here from the audience, I guess. What if we have a posterior capsular rent? So, and if we've taken a patient for a premium IOL, so what is the situation as a surgeon and in that case? Does it depend upon the size? Does it depend upon the, let's say if we have a zonular dialysis somewhere and with a PCR? Yes, Dr. Richard, we can have your opinion there.
Okay, I mean, it entirely depends on the status of the posterior capsule. If you've got a small break, which you can convert into a posterior capsulotomy that is continuous, then you can just put the lens in the bag. It isn't really a problem. However, if you've got a brig break or a linear break like you might get with a posterior polar cataract, that's a different issue. And it depends entirely on how stable you think the lens is going to be. If you've got to put it in a sulcus, then you can't put a multifocal in. It's as simple as that. I know there are some people in India who will take the bag out, put a multifocal in, and glue the IOL. This is not something that I would recommend. I think the possibility of getting that lens in exactly the right place, so you're going to get an emmetropic result, is unlikely.
Sure.
I think, I would just like to pitch in here.
Yeah.
In the sense, since we do a fair amount of multifocal intraocular lenses, we do have a library of 3-piece multifocal intraocular lenses. These are +4 diopter add lenses from the J&J platform. And in case the posterior capsule is just a small defect, if I can convert it into a posterior capsular excess, and I can introduce a multifocal intraocular lens in the bag itself, that would be my first choice. But in case the posterior capsular support is inadequate, and usually I ensure that it's a 4.5 to 5 millimeter excess. In these cases, I slip in the lens in the sulcus with an optic capture, and this works quite well. So we ensure that there is a library of 3-piece multifocal intraocular lenses available. Of course, if the first eye has had a multifocal intraocular lens and the incidence that has happened in the second eye, as Dr. Richard pointed out, scleral fixation of these multifocal intraocular lenses, even if they're 3-piece lenses, is controversial, because the exact centration of these lenses is extremely important for optimal functioning. But we have done that in a couple of cases because it was the second eye of the patient which was getting the surgery. But that's a situation that we'd rather not face.
Yeah, I think if it depends whether it's also, if you've got this situation, you've got a multifocal in one eye, whether it's the dominant eye or the non-dominant eye, because if the multifocal is in the non-dominant eye and you have the PCR in the dominant eye, when you put a monofocal in there, it will actually function perfectly well with that sort of monovision. If it's the other way around, that's a different story. And I think, again, you can still put a monofocal in and then patients would just change their dominance.
That's right.
So I think it's always useful to counsel when you counsel patients for all these premium IOLs to put in a word that if everything goes on fine, we'll go ahead with it. Otherwise, we'll go for a regular IOL. So that helps you face it and the patient to face it later.
Yeah, I think we all agree on the same, Kavita. And so Shikha, can we go for our next session? And
yes. With that, we'll begin the second session. I'll just share my screen and
share your screen, please.
Yeah. Is my screen visible? Am I sharing my screen?
Yes. Yes. So with this excellent first session, I now invite Professor Richard Packard, who was a consultant at the Prince Charles Eye Unit in Windsor, England from 1982 to 2016. He started using phaco emulsification in 1979, and in that year, he inserted the world's first foldable soft IOL during a rabbit study. Interestingly, in 1990, he implanted the very first Acrosoft IOL. To date, 125 million lenses of this material have now been implanted worldwide. He has lectured and operated in 61 countries in all aspects of cataract surgery and written many peer-reviewed papers and book chapters. He's a past board member of ESCRS from 1999 to 2007, and he's also been one of the judges for ESCRS video competition. Professor Packard, his latest interest is in laser capsulotomy, which stimulated the subject for his Binkos lecture at ESCRS in 2015. He published with Lucio Burato, The History and Evolution of Modern Cataract Surgery in 2018, and recently, the History of Refractive Surgery. With this brief introduction, I welcome Professor Packard for your talk, The Science of Multifocals and EDOF Lenses, the Concepts.
Mohan, you will have to share the screen.
Yes, ma'am.
Thank you for asking me to be part of this symposium to choose the right intraocular lens. My subject today is the science of multifocals and EDOF lenses, the concepts, and I have no financial interest in this particular talk. Benjamin Franklin is credited with inventing bifocal glasses in 1784. I mean, some think it may have been earlier, but certainly he was the one who popularized the idea of having lenses that do both distance and near. Where does the multifocal IOL story begin? Ken Hoffer in the USA was asked to see a patient with bilaterally subluxated shearing IOLs in November 1982. The patient had simultaneous vision of +20 and 0, but was undisturbed by this. Hoffer wondered if you could make a lens that was half distance and half with a +3 add. IOLab made them, but would not sterilize them without FDA approval. Ultimately, Hoffer persuaded our optics to polish and sterilize them. 2 were implanted with appropriate consent, and 1 patient did well and the other did not and was explanted. It would be many years before a commercial IOL using Hoffer's concept would appear, the Oculatus M+. And here we can see the explanted Hoffer IOL with split optic. But in fact, Hoffer was not the first to implant a bifocal IOL. This was done by John Pearce in the UK, who implanted the first lens, which was made by Precision Cosmet. It was near dominant with a PMMA optic. Other refractive designs swiftly followed. The IOLab New View, Stort's True Vista, the Ioptex, which had 4-zone multifocal, and the Right that had an aspheric optic. The first diffractive optic
arrived in the mid-1980s and was made by 3M. It looked promising, but the PMMA optic required a 7mm incision for implantation. This induced significant astigmatism, which compromised visual quality. 20% of the available light was lost, and a 1998 study showed that 66% of patients were spectacle independent. The next important development was the Allergan Array refractive multifocal on a silicon optic. There were 5 refractive zones. This was the lens that was used by Kevin Waltz for prelex, what he called presbyopic lens exchange. He found with this lens that 70% of patients could see J3 with distance-corrected glasses, but one of the major problems was glare and halos. In 2003, Alcon launched the Restore in Europe. This lens had a 3.6mm apodized diffractive structure centrally. The step height decreased peripherally from 1.3 to 0.2 microns. There was a +4 add, which equaled 3.2 at the spectacle plane. And then outside the 3.6 zone was a refractive zone. With the apodization, it meant that as the pupil size increased, a greater degree of the available light went to distance vision rather than near vision. And below you can see the defocus curve, which showed that it was clearly a bifocal. So what does apodization actually mean? Well, you get a gradual reduction or blending of the diffractive step heights. This optimally manages light energy delivered to the retina, and it distributes the appropriate amount of light to near or distant focal points, regardless of the lighting situation. It's designed to improve image quality while minimizing visual disturbances as compared to prior multifocal technologies. So what were my results like at 3 years post-op? On the left, you can see the binocular unaided distance vision, with 100% of patients achieving 20/25 unaided or better. On the left, we've got the reading vision with 100% of patients achieving J2 or better, so that there was good unaided distance and near vision, but unfortunately poor intermediate vision. In the next decade, many new designs appeared. The Restore changed from a +4 to a +3 add with an aspheric optic. The Technis multifocal appeared with a +4 add and a diffractive bifocal optic. The Resume had a +3 add and was zonal refractive. And the Acrylisa 366D had a +3.75 add and was also a diffractive bifocal. But one thing that remained for all of these lenses to a varying degree was glare and halos. And this was certainly one reason why many patients were put off, as well as their surgeons, from using lenses of this type. There had initially been reluctance to create a trifocal IOL because it was felt that the glare and halos would be worse than a bifocal. This proved to be incorrect, as we shall see. In 2010, another new lens saw the light of day, the Lentis M+, which essentially used the idea that we've seen from Ken Hoffer of having a split optic. This was an aspheric asymmetric distance vision zone, which was combined with a +3 sector-shaped add, which gave near vision. This allowed seamless transition between the zones. The Lentis M+ lens optic was constructed by combining 2 spherical surfaces with different radii. One main surface with a radius R1 and an embedded surface with a radius R2. The embedded surface forms a segment, which was a sector. The spherical centers of the 2 surfaces lie on the z-axis, i.e. the optical axis of the sector lens. The vertices of both surfaces coincide with the origin, and consequently, both principal foci of the lens were on its optical axis. Thus, an image displacement will not be possible. Here we can see the Lentis M+ MP30 defocus curve, and you can see that there's a very good range between -3 and +0.5, with good intermediate vision as well, even though the lens itself looks like a bifocal. The refractive design meant minimal dysphotopsias. However, there have been significant problems with lens opacification due to manufacturing issues, and thankfully these have now been solved. Using the same principles, the company has provided two other optic options with a +2 and a +1.5 add, the so-called comfort range. And you can see in the middle here the percentage of eyes that see better than logMAR 0.3 at all distances. These lenses give good unaided and intermediate vision, and this essentially is the object here. In 2010 also, the first trifocal IOL, the fine vision, was made by Vivior, and it was launched in that year. And you can see a comparison here between the monocular and binocular defocus curve for this lens, which again gives an excellent range of vision between -3 and +0.5. So how was the fine vision optic actually created? Well, what the fine vision IOL does was to combine two diffraction gratings to create a true trifocal design, one with a +3.5 add for near vision and one with a +1.75 add for intermediate vision. And this was the idea of Damien Gatinel. And when you lay the two on top, you can see in the middle here what the profile would be for this trifocal diffractive lens. So it's the size of the diffractive steps which determine the addition. And you can see the difference between the +3.5 and the +1.75. The fine vision, like the restore lens, is apodized so that the step height decreases from the center towards the periphery. And it's this diffractive pattern which is then pupil dependent, allocating more energy to far vision in mesopic conditions, very much again as the restore lens does. Another trifocal which appeared soon afterwards is the AT LISA Tri. And here the adds are a little bit different, with a +3.3 for near and a +1.66 for intermediate. Instead of there being an apodized surface, this is aspheric, but it's supposed to be aberration correcting. And what happens here is that the central 4.34 millimeters is a trifocal optic, and outside of this, from 4.34 to 6 millimeters, is a bifocal optic. The light distribution is 50% for far, 20% for intermediate, and 30% for near. And here's the LISA Tri bilateral defocus curve. It looks very similar to that of the Vivior fine vision lens. Looking at my own results, I achieved the majority of patients with a mean vision of 20/25, 6/7.5 for distance unaided. For near vision, this was J2 or better for all of them. And the intermediate vision was J5 at 70 centimeters. And none of my patients used glasses. There are other trifocals available using different ways to achieve this trifocality. The Rayner Ray 1 has a non-apodized surface with equal step heights. The Care Group Tri-Diff has a complex arrangement with an apodized optic. And the VSY Acriva Trinova has a surface which is completely different and uses a sinusoidal approach. The Panoptix is a quadrifocal. What this means is that it has a diffractive profile with 3 steps redirecting light and a 3rd step to distance. The intermediate add is 2.17 diopters, the near add is 3.25 diopters, and the light distribution is less dependent on pupil size than it was with the restore lens. So how does this compare with a traditional trifocal? A traditional difocal has 2 step heights and 2 add powers. Quadrifocal technology gives you 3 step heights and 3 add powers. But what happens in the Panoptix is that one of the step heights is actually pushed into distance, which gives you more light going to distance. It takes out the 120 centimeter range, but it doesn't really interfere significantly with the intermediate vision. And here we can see a comparison between bifocal and trifocal lenses if you consider the Panoptix as a trifocal. And it's mainly in the intermediate distance that you can see the difference.
And as far as contrast sensitivity is concerned, the Lentis M Plus does better than diffractive, particularly at mesopic levels of light. The Panoptic seems to do better than the fine vision, and the laser tri is well within the normal range compared to an age-related group. Extended depth of focus, EDOF IOLs, use many different technologies to achieve their aim, to enhance the range of vision to allow greater spectacle independence for many live tasks without providing the full range of a trifocal. Let's have a look at some of these. Let's look at two IOLs that have modified the diffractive optic to achieve EDOF. Symphony has a monochromatic aberration-free diffractive optic with echelettes optimized to achieve maximum grating efficiency in a given diffraction order. The AT Lara is a diffractive optical design with far dominant light distribution and two power additions, creating an optical bridge effect to extend the range of focus. And you can see this in the diagram on the right, comparing their defocus curves. Or you could combine two different optic technologies, as in the fine vision Triumph. Here we have chromatic aberration-free design, which corrects longitudinal chromatic aberration. Like the original trifocal, the fine vision Triumph is designed with two bifocal elements, one for distance and near, one for distant and intermediate. The width of the steps is the same in both lenses, with additions of plus 350 and plus 1.75 diopters for near and intermediate vision. And the step heights between the two elements are higher in the fine vision Triumph, and that's the major difference in the design. And you can see that it has an extremely flat defocus curve compared with some lenses which tend to have ups and downs. Another approach is the combination in the Synergy IOL, where there's a combination of the bifocal diffraction grating of the Technis Multifocal for a focus at 33 centimeters and infinity, with the echelettes for the Symphony for foci in the 40 to 80 millimeter range. And that again is reflected in the defocus curve. The pinhole can also achieve EDOF. This is a hydrophobic acrylic IOL with a centrally located opaque annular mask measuring 3.323 millimeters, and in total diameter with a 1.36 millimeter central aperture. And this will achieve a defocus curve which certainly is different from that from monofocal IOL with a greater range. The Miniwell Ready IOL has another approach. It uses wavefront technology to enhance the range of vision and compensate for presbyopia. Each of three circular zones of the IOL have different aspheric profiles. And this creates a range of focus that can provide patients with spectacle independence at multiple distances. WIOL has an aspheric hyperboloid optic, and this can improve the quality of vision, giving a greater depth of focus, providing pseudo-accommodation and eliminating spherical aberrations. This lens can be deformed by the action of the ciliary muscle, and you can see the defocus curve on the right, which is very flat compared with some of the other lenses that we've already seen. Now we can have a look at enhanced monofocals like the Technis iHance. This provides a continuous change in power from the periphery to the center of the lens, creating a unique anterior surface that improves intermediate vision. It maintains distance image quality, which is comparable to aspheric monofocal IOLs. And it delivers a profile of photic phenomena, which is similar to the Technis monofocal. It also reduces spherical aberration to near zero. And you can see the sort of profile of the defocus curve there on the right. The Vivity lens takes a different approach. Vivity uses wavefront shaping technology and consists of a 2.2 millimeter central zone with two surface transitions of the wavefront to create, firstly, a smooth elevated plateau, which extends the focal range, and in its center, a small curvature change which shifts the wavefront to create an extended negative focal range. And the result is an enhancement of both intermediate and near vision, but no loss of central acuity. Here we can see the results of the US and outside US trials, comparing a monofocal lens with the Vivity. The Ray 1 EMV is designed to enhance the monovision approach. It provides 2.25 diopters of extended depth of vision with a 1 diopter offset, provides superior intermediate vision when compared with standard monofocals, and reduces dysphotopsias compared with diffractive multifocal and EDOF IOL designs. Also provides a smoother blended transition between the dominant and non-dominant eyes when compared with standard monofocals, maintaining binocular stereoacuity and reducing austenopia. And this one, which uses a limited diffractive optic, the exact lens, the exact mono EDOF, it's a monofocal lens with 4 diffractive rings and a broad single peak of focus. According to the manufacturer, this lens offers patients exceptional uncorrected intermediate and distance vision. And contrast sensitivity is the equivalent to that of a monofocal IOL. By having so few rings, you would not expect there to be significant dysphotopsias. Well, you and your patients certainly have a big choice. Or will you wait for an accommodative IOL where you're moving fluid around, like the fluid vision lens or the Juvene lens? Thank you very much for your attention.
That was a wonderful talk, Dr. Packard. We'll take the questions after Dr. Sudarshan's talk. It's my honor to introduce Madam. Dr. Sudarshan is presently the Deputy Director of Department of Uveitis, and she is a member of International Uveitis Study Group, and she has served as the President of Uveitis Society of India from 2012 to 2015. She has authored the Atlas on Uveitis, which was the first atlas on uveitis from India. And she is the co-investigator in several multicentric international clinical trials in uveitis. Her areas of interest include ocular inflammation, cataract surgery in uveitis, and infectious uveitis, research related to ocular inflammation. So with that, I invite Madam to tell us more about Synergy, the new lens from J&J. So we usually, the Cataract Update team tries to have a discussion before these lenses are introduced in our hospital. In our 16th update, we had discussed eye-hands lens, and now it's about Synergy, and probably next time we'll discuss Vivity.
Thank you, Shika, for the wonderful introduction. So I just have a presentation of about 10 to 12 minutes trying to understand Tecnis Synergy. So coming to the current presbyopia correcting IOLs, the options that we have, as we have seen in the previous lectures, are the multifocal, the accommodating, the trifocal, and the extended depth of focus IOLs. The multifocal IOLs split the incident light into 2 or more points of focus. They improve the near vision and provide spectacle independence. The multifocal IOLs are limited by demands of minimizing optical aberration and balancing the focused and out of focus images, which is associated with glare or halos. The EDOF IOLs provide an extended range of focus with a functional vision over a range of distances and apparently reduce halos or glare. Despite the numerous IOL options today, patients still struggle to find a lens to perform at their ideal distances and lighting conditions. So different PC-IOL technologies create specific gaps within the patient's visual range. As you would see, the multifocal IOLs have a gap in the intermediate vision, whereas trifocals too have visual gaps. The Tecnis Synergy IOL is a presbyopia solution that delivers continuous high contrast vision from far through near, even in low light conditions. The continuous vision across the range empowers patients to see at their ideal distances, and it also provides superior low light contrast and delivers high quality vision day and night. So what is the technology of Synergy? Synergy combines some of the best features of the existing bifocal and the EDOF lenses. It combines the diffractive technology from Technis Multifocal and the EDOF technology of the Technis Symphony for intermediate vision to deliver continuous high contrast vision across the range. As we know, the Technis Multifocal delivers a good distance and near visual acuity with a pupil independent design, whereas the Technis Symphony delivers continuous vision across the entire range, and it also corrects the chromatic aberration to optimize the contrast vision, and it also has a pupil independent design. So coming to the Synergy, the lens design, like the Technis Multifocal, Synergy has two distinct focal points, approximately 33 centimeters and at infinity. And like the Symphony, the Synergy incorporates the EDOF diffractive Ichillet technology, and the EDOF portion of the lens is in the near to the intermediate range between 33 to 80 centimeters. So now the IOLs which have a combined optic design are termed as hybrid IOLs. Synergy is a bifocal combined with the EDOF technology for intermediate vision. Its posterior surface is diffractive with 15 rings. It features a wavefront designed aspheric surface. It corrects the chromatic aberration similar to Symphony and has a potentially better visual continuity than a trifocal lens. Hence, Synergy is a hybrid multifocal refractive diffractive EDOF IOL. So if we look at the defocus curves and the Synergy, the first graph shows you the defocus curve of the Technis Multifocal and the Symphony. If you look at the Technis Multifocal, the defocus curve drops off at the intermediate vision and picks up for the distance, whereas the Symphony, the defocus curve drops off towards -3, mostly for the near vision. The predicted defocus curve for the Synergy is almost flat. If you look at it from 0.5 to -3, you get almost a flat curve. That's what is predicted, and that's what it is supposed to deliver. It provides a continuous vision. It delivers the in the zone continuous vision from 33 centimeters to distance. If you look at the graph here, the zone is the area of visual performance which happens between 2020 and 2025, right from 33 centimeters right up to the distance. So the in-zone continuous vision empowers patients to see at their ideal distances. The continuous vision across the range bridges the visual gaps that are left behind by trifocals. So Synergy IOL appears to deliver in the zone visual performance, surpassing the pronounced visual gaps of the Trifocal Iol technology. So if you see here, this is the graph of the Synergy IOL, which is performing in the zone where compared to the other lenses, where you can still see a few visual gaps. In addition, Synergy also corrects the chromatic aberration with the chrome-aligned technology. The correction of the corneal chromatic aberration results in a sharper focus of light, and the achromatic technology like Symphony is available on Technis Synergy. This is what it provides. And the chromoline technology results in an enhanced image contrast across the range of vision for far, intermediate, as well as for near. Now coming to the LED light, the LED lighting is creating a challenge for a good vision quality in low light conditions. And we are rapidly adopting the LED lighting, and which is one of the fastest technology shifts in history. So this LED light produces a high level of scatter due to emission of the shorter wavelengths of light, especially the violet light. It's somewhere here. So Synergy offers a better image quality because it filters the UV light and the violet light, and blocking these wavelengths reduces the light scatter, improves the contrast sensitivity, reduces the halo intensity, especially useful for easier driving and device use. So the violet light filtration blocks the shortest wavelengths of light, which produce the highest level of scatter, but it transmits the longer wavelengths of light, the blue light, that is needed to maintain the circadian rhythm and the low light vision. In addition, we know that spherical aberration is associated with the focal length difference between the central and the marginal ray where it enters the lens. So as in all Technis IOLs, Synergy incorporates a negative spherical aberration to correct the corneal spherical aberration And it is also made from a material with a high Abbe number with a low rate of dispersion. So this is the high quality vision with proven techniques platform corrects both the spherical and the chromatic aberration. And this is the quality of vision that it is supposed to deliver. Techniques Synergy also delivers a pupil independent performance, where the pupil size independence of this Synergy IOL contributes to the best low light performance compared to the leading trifocal IOLs. If you look at this graph here, the MTF loss when the pupil opens up from 3 millimeters to 5 millimeters is least with the Synergy. This superior low light contrast also empowers patients with a high quality vision during day and night. Again, these are two graphs comparing different IOLs when the pupil is around 3 millimeters and 5 millimeters, where you see the Synergy performing better when the pupil dilates even up to 5 millimeters. Now coming to the trade-offs and the Synergy effects, if we may call it so. The trade-offs are the photic phenomena do occur as with any other multifocal IOL. It is essential to achieve a near planar result, and the residual refractive error, especially the residual astigmatism, will degrade the visual outcome. In this sense, the Synergy is not as forgiving as the Symphony or the EDOF lens, and Synergy is currently available only in sphere powers and is not suitable for patients with more than 0.5 diopters of a predicted residual astigmatism. So this is a study done in Spain by Dr. Ang et al., where they studied about 108 patients bilaterally implanted with Synergy vis-a-vis 54 patients bilateral implantation of PanOptics. And what they conclude is that Synergy provides benefit over PanOptics with a broad range of continuous vision from 33 centimeters and to distance, and a decreased frequency of spectacle wear at all distances. And Synergy demonstrated an exceptional visual performance from distance to near, and both IOLs had patient satisfaction, and however, they had a very similar dysphotopsia profile. And of course, this is some of our Indian surgeons' experience with the Synergy IOL, which was shared at the DOS meeting. Dr. Ramamurthy is also here. So Dr. Ramamurthy had implanted about 6 lenses. He was quite impressed with the mean defocus curve from 0.5 to a minus 3.5, which was an absolute flat curve. And Dr. Sri Ganesh also felt that it was a lens which provided good distance, intermediate and near vision, and the mean visual acuity of 6.6 or better through a 1 diopter of defocus with a good reading speed. They did have dysphotopsia, but the contrast sensitivity was closer to Symphony, better than trifocals, with 100% spectacle independence. And many of the other surgeons also felt that the visual gaps were absent, and this was a welcome lens with a very high quality of contrast vision. So I thank you for your patient hearing, and I have a short video provided by Johnson & Johnson, if we can play that. Mohan, can you play the video? Video, can you play the video, please?
Patients have many diverse interests and often require a vast range of high-quality vision to meet these needs. Despite numerous trifocal and multifocal options today, patients still struggle to attain high-quality vision at their ideal distances and lighting conditions. Introducing Technis Synergy, the continuous range of vision IOL from Johnson & Johnson Vision. The Technis Synergy IOL is a breakthrough innovation in presbyopia correction that applies a synergistic combination of EDOF and multifocal technologies. to deliver continuous high contrast vision from far through near, even in low light conditions. The profile of the 15 diffractive rings of the Technis Synergy IOL creates constructive and destructive interference to optimize light distribution. This modification of the diffractive profile and base curve alter the phases of light. This results in a lens that delivers continuous vision from distance through 33 centimeters. Laboratory testing using an average cornea eye model to visualize the light passing through the lens demonstrates the visual performance of the Technis Synergy IOL. The Technis Synergy IOL produces light focus continuously through the range of vision. The Technis Synergy IOL also features color line technology, which corrects chromatic aberration by bringing both high and low wavelengths to a condensed focal point, and optimizes image contrast over the full range of distances. In addition, violet light filtration works the shortest violet wavelengths, which produce the highest levels of scatter, while transmitting the longer blue wavelengths. This results in higher image quality through enhanced contrast, and is intended to reduce dysphotopsias by eliminating the visual side effects induced by both advanced IOL optics and the increased use of LED lights in today's world. The transmission of beneficial blue light allows for improved scotopic sensitivity and reduced visual symptoms, as well as improved nighttime driving experiences. Healthy blue light also allows for better systemic health, mood, and sleep. These features, along with the pupil-independent design, enable Technis Synergy IOL to deliver superior image contrast in all lighting conditions compared to Trifocal IOLs. Technis Synergy IOL is a breakthrough innovation in presbyopia correction that applies a synergistic combination of EDOF and multifocal technologies to deliver continuous high contrast vision from far through near, even in low light conditions, which is essential to the way we live in the modern world. Technis Synergy IOLs. Continuous vision across the range empowers patients to see at their ideal distances. Superior low light contrast delivers high quality vision patients can trust day and night. Get the best of both worlds. Focus far through near. Clarity day and night.
Well,
Thank you. That was
indeed a great insight into these premium lenses, and we really look forward to the new lens, Synergy intraocular lens. So let's go to the new set of questions. Our interesting audiences, they have put up some questions as we see. So besides the intraocular lenses, what are the latest technologies that we can all know about these phacoemulsification?
I'll share this. Just a moment, Mamta. Let me just
you want to
share the screen. Yeah, I'll share the screen. So once you can, just read out all the questions so that, we can discuss later. Yeah.
And then another question is that what is the importance of the Q value and angle kappa in multifocal lens implantation? Dr. Ranveer from India, he wants to know how about the night vision effect in patients who have been with eye-hands lenses? And what is the recent suggestion in choosing the intraocular lens power in the absence of technology for appropriate biometry? From Nigeria, he wants to know how do we calculate and how do we choose IOL power, considering that we do not have an appropriate biometry. So would like to have our esteemed panel to take up these questions, and let's see. Dr. Armia, you want to take?
I can start from the last question.
Okay.
Because the last question, I think nowadays in all this technology we are talking about, there is no place for this. this is so difficult that you are going to do a cataract surgery for a patient and you are not going to calculate the intraocular pressure in the intraocular lens in the right way. No place for this. So either he referred the case to a place that he can take a proper IOL calculation. Because if we go back like this, maybe 30 years since I start, it was like you put the axial lens and you see the refraction of the patient and you calculate, and you are going to see the post-operative refraction, a lot of mistakes. This is cannot be seen. I want to hear Dr. Richard how you are going to comment on this question, because this is so weird question.
Yeah, I'm just wondering whether, in fact, he's referring to having an optical device or using a scan. And I think the point here is, if you have got a scan, then you have to learn how to do immersion a scan, because actually the results with immersion a scan, if you know how to do it, are really not that bad by comparison with not doing it at all, obviously. And also, if you're using contact a scan, it's quite easy to get an inappropriate result. I think the problem is that if you really haven't the possibility of nailing the biometry properly, you can only use a monofocal lens and a bit of prayer and hope that it works out for you and the patient.
I think, if I may, I mean, refractive accuracy is absolutely essential as far as multifocal technology is concerned. But I know of several colleagues in India who do not have access to the optical biometers. Obviously, it would be a very good investment if you're going to do premium intraocular lenses. But that does not mean that you need to wait for an optical biometer before you go on to toric intraocular lenses or optical biometers. As Dr. Richard pointed out, it's extremely important that if you're going to do a scan, it has to be immersion A scan and not contact A scan. The advantage of an optical biometer is that it's idiot proof, in the sense that, even if the person doing it is not so well trained, especially in normal eyes, you get most often the correct readings. But then a trained technician doing an immersion A scan can also get absolutely predictable, repeatable readings. And then you have now these calculators like the Parrot suite of calculators, which is what we resort to in all our cases, is of course incorporated in many optical biometers, but it's also available in the ACRS and APACRS websites. So what we do is there are some centers of ours where we do not have optical biometers, but we have very competent surgeons. So we encourage them to take on the multifocal intraocular lenses also. So they take the inputs from the immersion A scan with the automated keratometer, then subsequently feed it on to the ACRS or APACRS websites and use the Barrett suite of formula to calculate the intraocular lens power. Of course, if it's a presbyopia lens exchange that we are doing, or if it's a extremely high myopic or a hyperopic eye, where or a post-refractive surgery eye, where obviously there are challenges, then we would definitely say that having an optical biometer is important. But if you are considering implanting multifocal intraocular lenses in normal eyes, then maybe it's not an absolute must that you need an optical biometer before going ahead with these multifocal intraocular lenses, provided you understand your biometry very well.
If I may ask you here, is it always that we always check on two devices, the intraocular lenses, the powers, and the biometry? Is that a normal procedure that we check it on two devices and we confirm the values, or we have a competent optometrist who is doing this biometry and we go ahead with that?
I think that, look, the critical thing is axial length with optical biometry is not an issue anymore. It's very accurate. If you look at the potential errors for getting the lens right, it's getting the effective lens position right, which is the most important thing. What I would say is, what you do need to use multiple devices for is looking at the keratometry. Using just an IOL master or a lens star and taking the K readings from that is not good enough.
Okay.
You need to use placido disc topography and pentacam as well, because if you haven't, for example, you were talking, Ashraf, about ocular surface disease. If you use posterior disc topography, you will see, even if you can't see it yourself when you look clinically, the result that you get with that will be broken up, and you will know that there is a tear film issue. When you're using toric lenses, you need to have that nice warm feeling that you've got the same K readings on your IOL master and on your topographer and on your pentacam. And then you know you're going to be working well. However, if they don't match up, then there's almost certainly going to be a tear film issue. And these patients are going to need to be looked at very carefully. They were probably going to have some lubricants for a week or two to stabilize the tear film. Then you do the measurements again. And sometimes you'll find that what you thought was 2 diopters of astigmatism doesn't exist at all. It just disappeared.
So when we are talking about the axial length, as Dr. Richard, you've mentioned, so what about the eyes which have dense media haze, and our optometrists, they will just come back with that they're not able to freeze it. So the axial length, however, so do you think optical device?
No, modern machines, with the IOL Master 700 now, 97% of eyes, you can get a result.
Okay.
So it's not really so much of an issue. Obviously, in India, there are going to be more eyes with denser cataract.
Exactly.
And then you have to use your immersion A scan. But by and large, those are not going to be the patients that are going for multifocals anyway. Because I suspect most of the patients that come forward for multifocals are the more discriminating patients who will have done some research on this. They won't have let their cataracts get to the level of perception of light only. I mean, you can correct me on this, but that will be my impression.
Yes.
Yeah.
Actually, there are quite a few patients with fairly advanced cataracts who also want the benefits of multifocal intraocular lenses. But as was pointed out, with the swept source-based technology, where there's a beam sweeping across the lens, it invariably finds certain areas through which it can go and acquire information as far as the axial length is concerned, which is quite reliable. And we find that with our optical biometers, not just the IOL Master 700, there are a couple of other swept source-based machines also. Most often you get a very reliable axial length measurement. It's more often the keratometry which is a challenge.
Yeah, absolutely.
And
one question to.
Okay.
Sure, Dr.
Yeah,
Almia.
the people that leave the cataract to be more hard are commonly the high hypermetropic eyes, because the nuclear cataract continue to increase, and they are improving in the distant vision, and they are denying that there is any problem. And even when you have a grade 4 in high hypermetropic and you are telling the patient you have a very hard cataract, sometimes he cannot understand why you say I'm seeing well. This is a lot of my patients like this.
Yeah, you're absolutely right.
Yeah, true. Actually, this is a very common scenario. It's very difficult to explain about the density and the vision because it doesn't correlate. And they feel that we are reading the last line on the charts and we are advising a cataract surgery. Very true. So how about that one of the other question where we have the night vision and eye hands? Do you think we have some kind of a problems there? No.
It's exactly the same as a monofocal at night. It's not an issue.
Yes.
No issue.
So taking off from here, just one question to the panel and especially to Dr. Ramamurthy, that in the first talk, when Dr. Iol mentioned that when you want to really play safe, it's Vivity or eye hands. Where does synergy fit into it? You've used synergy and any now that's the new thing in the market. So everybody is talking about Vivity and eye hands, very safe options. Any inputs about synergy? We're going to start with synergy. So,
if I might, I've had the experience of implanting the Vivity and the eye hands also, and was quite excited about it. But these are essentially monofocal plus lenses, in the sense that it adds a little more to what you can offer to a monofocal, but maybe some amount of intermediate vision, and you don't actually any kind of mix and match or monovision is not something that's recommended. You try to aim at emmetropia. So I'm frankly not too excited about both these lenses because I believe that these are meant for patients who are not fit for multifocal intraocular lenses. Any patient who is seriously interested in multifocals, basically these lenses are not the way I would go for. But as far as the synergy is concerned, it was, of course, the initial 6 lenses. My experience with Dr. Sudha Ganesh talked about that was before the lenses were commercialized. Now that they are commercially available, we have implanted a significantly more number of lenses and few of them for prelix situations also. And we are quite excited about this lens in the sense that the amount of dysphotopsia that these patients, of course, it's again initial experience spanning over a period of just a couple of months, and dysphotopsia compliance is not there. The most exciting aspect is the very flat curve that you get, the defocus curve, right from about 35 centimeters up to the infinity. I believe that's an extremely good addition to the platform of lenses that we have. And based on the fact that it's a good hydrophobic acrylic material with a minus 0.27 asphericity and with the chromaline technology, it seems to be a good lens. But having said that, I've also had good experience with the trifocal lenses, especially the panoptics. And I feel that those lenses also give very reliable, extremely good results. So essentially, we're in a very advantageous position today to pick and choose for our patients. And, you know, we have the freedom of choice. And it's good to have these choices, though at times it's a little confusing.
So whom will you offer panoptics and whom will you offer synergy?
That's a difficult
How
question.
do you pick and choose? Is there a special advantage of synergy over panoptics?
Actually, you know, we have been using panoptics for quite a long time. Did a multicentric trial also, prospective trial, in which Shankarnetralaya was also involved. And the results were extremely encouraging. And I think that's been the worldwide experience. It's not that none of these lenses, including the synergy and panoptics, patients do not have dysphotopsia. Let's forget about it. When you talk about multifocals, dysphotopsia is a price you pay. It's only a degree of dysphotopsia that we are talking about. So essentially, I have not clear-cut guidelines as to where I will offer a lens like panoptics and where I will offer synergy. I believe that both these lenses are good platforms, and the kind of results, at least I have seen initially with synergy, is as good as what we got with panoptics.
Very diplomatic.
And how does synergy? Yes, sir.
According to the availability in your center, the availability of the power.
Want to say something?
And another thing is, how does synergy compare with its own multifocal?
Which
If
one?
it's
J&J multifocal, they also have a multifocal.
Well, then
that
that's
is
no. It's very different, because the J&J multifocal, which is the thickness multifocal, is basically it's a bifocal and it has a +4 add. It's not the same at all. They've taken part of that and they've put it into the synergy, combining it with the symphony, so that you've got the two on the same optic. But you wouldn't want to put in the thickness multifocal now. I mean, it's an out-of-date lens.
So it's symphony and
what the HLA design of the Symphony does for intermediate to distance vision is what the HLA design of the Synergy does for near to intermediate vision. So basically, when you talk about Symphony, you are talking about from 60 centimeters to infinity. Here you are talking about 33 centimeters to infinity. And the 33 to 60 component is what is taken care of by the HLA design in the Synergy. I think they have basically combined the best of both worlds. That is the advantage of excellent near vision of the diffractive lens with the quality of vision that the HLA design used to offer in the Symphony. And basically, as Dr. Richard pointed out, the +4 diopter original diffractive lens, or for that matter, the +3.25 or 2.75 lenses, and the Synergy are completely two different lenses. As we saw in that earlier presentation, the dip you see for the intermediate vision that's there with the diffractive multifocals is not there with the synergy lenses, or for that matter, for some of these modern trifocal lenses also.
I mean, the
That's
fine
the
bit
major
Triumph
advantage.
has done the same thing by introducing this EDOF bridge in the middle of the trifocality. You flatten out the curve, and as you saw in my presentation as well. And I think it's very clever. I mean, the way that these optics have moved on from where we started with the original diffractive bifocal lenses. And what we have to offer our patients now is extraordinary. And you're quite right, Ram, that the dysphotopsias are really so minimal now. I mean, patients know they're going to get them, and you tell them they're going to get them, and they say, yes, I've got them. But as we know from the longitudinal studies that by the time you get out to a month or two, they're not even noticing them at all.
Absolutely.
Another question is there from the audience that if a patient has had retinal surgery, which IOL, if the patient wants some amount of intermediate vision or glasses, spectacle independence, which options are there?
Post-retinal surgery, I am going to recommend the monofocal IOL, nothing more, because you cannot guarantee that this retinal surgery is going to be recurrent or no. And whatever the retinal surgery is gave a best results, no guarantee that they are going to be recurrent or no. So I'm going to put a monofocal, just monofocal IOL.
Yeah,
basically,
would you like
Shrikar,
to add
these are
something?
You're asking me?
Yes, sir. Yeah, maybe
Yes.
after Dr. Ramoti, you can do.
Okay. Sorry, I hope I'm not talking out of turn.
No, sir. Please go ahead.
Okay. No, basically, these are the instances where I would go for eye hands or a VVT. In the sense that the patient has heard about multifocal intraocular lenses, but they're not ideal candidates for a multifocal intraocular lens. So basically, these are the patients with controlled glaucoma or who have a certain amount of dry ARMD and whose corneal surface is not optimal, who have had prior refractive surgery, or as you say, prior retinal detachment surgery. So obviously, these patients are not good candidates. Wherever there is already an inherent loss of contrast, these are not patients good for real multifocal intraocular lenses. So you go ahead and offer these monofocal plus lenses, which gives a little amount of intermediate vision, but at the same time does not take away any contrast. So these may be the limited situations where I would go for a eye hands or a VVT lens.
So are we telling that, if I understand it correct, eyes with some comorbid conditions, eye hands is still an option?
Absolutely.
Oh, yes.
Absolutely. Post-refractive surgery also.
Post-refractive surgery. And
Manish, you want to add anything?
Yeah, I would agree with Dr. Ramurthy that IHANS is a good option. It's essentially works like a monofocal lens with some amount of intermediate add. And when we are talking about the retinal surgery, I think we are to be a little more specific about the macular status also, because a patient who has undergone surgery for removal of epiretinal membrane over a period of time, he does end up with 6/6 vision. And in those cases, probably enhanced depth of focus IOL may be an option. So if it's a retinal detachment surgery, macula has been, is affected significantly, then probably monofocal lenses or at the most IHANS is an option. But otherwise, where macular status is not really affected, then probably extended depth of focus might be considered in certain.
Also, I think if somebody's had a U-tear with a localized upper temporal detachment, where the macula has not been affected, the retina has been flattened, the U-tear has been sealed, and they're not a high myope, but just they had a posterior vitreous detachment which caused the retinal tear, I see no reason why they shouldn't have a full multifocal, because essentially their eye has been returned to normal.
okay.
Yes, sir.
But what about, Dr. Richard, that what if he has a recurrence? If he has a re-RD?
Those sort of eyes just basically don't get recurrent detachments. They really don't. As somebody that's had a PVD, they get a localized tear. There's no major detachment. It's very, very unusual for them to get a significant recurrence.
Mm-hmm. And one more question I just want, when we're talking about these IOLs, the panoptic synergy, I would like to ask, when we know about these glistenings, so do you have these experiences too, that one has more propensity than the other? Let's say the Technis IOL versus the panoptics. Are we bothered about these glistenings in these IOLs?
No. I investigated glistenings in the 1990s. And every single paper that has been written about glistenings shows that there's something you wouldn't want to have there, but you only see them when you use a 45-degree slit lamp beam. Patients don't see them. In the same way that they don't see asteroid hyalosis, which is far worse than glistenings. If you actually look at them, you know, when you look into an eye with asteroid, you think, how does the patient see anything? But because the light is going straight through it rather than at an angle, it doesn't cause a major problem. And I'll kind of address this anyway with the new Clarion material. And I suspect that that will be used as the base material for all of their lenses as we go forward as well.
That's really helpful.
I completely agree with Dr. Richard in the sense that glistenings is something a lot of noise is made about, but though having used the Alcon lenses are the most blamed for that. But I mean, I use all kinds of lenses, but I've not explanted a single lens so far because of glistenings, which significantly bother the patients. Occasionally, you come across a few glistenings which you see at a particular angle on the slit lamp, but the loss in, leave alone loss in visual acuity, even loss in contrast sensitivity is not something you commonly come across. As of now, the Panoptics is still on the original material, but I think soon it will be the Clarion material. But I believe that even the original material works quite well. And you can get glistenings with any lens, whether it's PMMA, hydrophilic, hydrophobic, with any company.
Shikha, can we go to the next now?
Yes, with that, we'll go to the next session. And for that, we'll invite Dr. Ashraf Armia. Just a minute, I'll share. Am I sharing the screen? Yes.
This is different. Shikha?
Yeah.
No, this is a video which you are playing.
It's a video that's playing?
Yeah, you have to share your PPT.
Okay, Mohan, I think you have started sharing the screen. You don't have to share the screen, Mohan. Can you please? Yeah. Yeah. Sorry for this confusion. Just hold on, Mohan. After the... Yeah. Can you see my screen now, Mamta?
Yes, yes, we can see. So with this wonderful discussion, I invite our next speaker, Professor Ashraf Armia from Egypt. And he's a well-known surgeon specialized in cataract surgery, refractive, corneal surgeries, and anterior segment reconstructive surgeries. He's a fellow of the Royal College of Physicians and Surgeons from Glasgow. He's also a fellow from American College of Surgeons for ophthalmology. He's the founder of Armia's Ophthalmology Training Observership Academy in Giza, Egypt. And he's also the founder of Global Education and Research Society of Ophthalmology. With this short introduction, I invite Professor Armia for his talk on toric IOLs in steep cornea and keratoconus cases. Professor
Armia. Thank you so much for the invitation, Dr. Mamata and Dr. Shikha, and it's a great honor to talk after Dr. Aliou and Dr. Richard, two worldwide global mentors in cataract and refractive surgery. So I hope my presentation will going to add something in this very crucial part in cataract surgery, which is the steep corneas and keratoconus, how to calculate the IOL. I have no financial
slide, Professor Armia, sorry.
Sorry, you cannot see my screen. Yeah.
I think we are
no. I'm so sorry. I have to stop sharing the screen. Yes, now yes. You may share.
No, we cannot.
I can share my screen now, yeah?
Yes, yes, you can share yours.
Okay. You can see my screen, yeah?
Yes, we see
Okay. So my talk will going to be about the toric IOLs, which is one of the crucial steps in cataract when there is a steep cornea or a keratoconus. I have no financial disclosure, but these are my financial disclosure. So with the improvement of the instrument and the technology in cataract surgery, the most challenging subject in patient satisfaction is the post-surgical refractive outcome. And although new optical biometry systems have improved the intraocular lenses power calculation, result by accurate and reliable axial lens and keratometer measurements, effective lens position is still a matter of debate. So the third generation formulas are the most popular theoretical formulas which predict the IOL position by the axial lens and the keratometer. The Hages, the Olsen, and the Holiday 2 formulas utilizes 2, 5, and 7 parameters for prediction of the eye position, respectively. So when we talk about corneal ectasia and steep cornea, we should know that it's a progressive steepening and thinning of the cornea, and it's a multifactorial condition. And the most common corneal ectasia is the keratoconus, but it can also follow a keratorefractive surgery, which is more commonly in excimer laser ablation, radial keratotomy, and also recently we see it in post-smile techniques. So if we are going to say it's a progressive corneal ectasia, it's going to lead to myopia, irregular astigmatism. So there is a wide range of K values in small area, and this will lead to changes in the anterior chamber depths, which make it more difficult to calculate the effective lens position, which is a crucial step in calculating a normal, the perfect IOL power. So what about the corneal ectasia? Again, when we talk about corneal ectasia, it's common in keratoconus and post-refractive surgery ectasia. Post-refractive surgery ectasia, it's a resembled keratoconus. So all the condition will going to be an IOL calculation. We will think in all different corneal ectasia as a one entity, either keratoconus or any post-refractive surgery ectasia. Before we calculate an IOL in any corneal ectasia or a very steep cornea, we should have a stability. So stability, it's a calculate the lens to be more confident with the cornea stability. Other than this, it will not going to be a proper IOL calculation. Also, never calculate a lens in a fluctuating cornea, and usually advise the patient about the small risk of corneal decompensation and ectatic progression after surgery. And in any corneal ectasia progressive, we might want to cross-link the patient first to stabilize the cornea before calculating the lens. But very important to rule out the progressing ectasia by recommendation. This is very important to perform 3 corneal tomographies 3 to 6 months apart from each other. This is very important. Again, in corneal ectasia and keratoconus, it's a challenging in biometry. 3 basic measurements are included in all the different formulas: the axial length, the corneal power, and estimated lens position. So the steeper cornea and the off-centered apex make it difficult to obtain an accurate keratometry readings. I'm highlighting this in red because this is very important. Ectatic eyes have higher axial length and deeper anterior chamber, which this making the effective lens position harder to estimate. As the apex is an off-centered in these cases, it might not be the visual axis. And this means that the corneal case measures in the apex or of the cornea might not be the case we have to use for our calculation. So we have to decide what optical zone we are going to use. And you should know that the larger optical zones we are going to overestimate the case, including the off-center corneal apex in the calculation. we have two biometrics, either the ultrasound or the optical. The ultrasound, it is inaccurate in ectatic corneas. Optical biometry is preferred for axial lens measurement due to the acquisition of it in the visual axis. Dr. Aliu and Ital enforced importance in the accuracy of the axial lens in these patients, showing a strong correlation between the preoperative axial lens and the postoperative spherical equivalent. Optical biometry, we have two main now, the recent. The first one is the PCIL Master 700, and the other one is the OLCR devices, which is the LensStar, the new version, the LS 900. What is the difference? The IOL Master will not consider this an absolute truth. In the fact, we might want to compare our case with the other devices like the corneal tomography and maybe use other case for our calculation. You must know also that the IOL Master does not acquire all the measurement in one sweep. And this is a disadvantage in ectatic corneas due to the big variation with small areas. But in the LensStar, the advantage of taking all measurement in a single alignment and single sweep, improving the accuracy of individual measurement and increasing the repeatability. There is another advantage in the LensStar, is that it's incorporate the Barrett-Torrey calculation within its formulas. As in the IOL Master, the optical zone where the K values are calculated is good for normal eyes, but small for the patient with corneal ectasia, not giving a good results. And it also makes assumption about the posterior curvature. What about the corneal power? The corneal power is an important aspect to understand the total corneal power is given by the anterior and the posterior cornea, meaning that measuring only the anterior cornea and assuming a fixed value for the posterior cornea will not give the accurate enough. So there is a wide variety of devices to measure the corneal power, but not all of them are reliable enough for these eyes. Very important to know that the automated and the manual keratometry devices, the topographic devices, the IOL Master, the LensStar, will only measure the anterior corneal surface and make an assumption about the posterior curvature. It has been published that the automated keratometry has bias overcorrecting and undercorrecting the corneal astigmatism, either with the rule or against the rule astigmatism. So the corneal power, we have four to measure. The first is the manual keratometry. Measure the central 3 millimeter of the cornea and measuring the anterior surface and making assumption regarding the posterior surface. In the automated keratometry, most devices measure the central 2.8 to 3.33 millimeter of the cornea. And due to the greater variability in the diopter within different areas of these corneas, measuring only one small area is not enough to have an accurate result. What about corneal topography? It measures the anterior cornea curvature and it will calculate elevation using the slope. It will make assumption of the posterior cornea curvature as assigning it to a fixed value. Ectatic corneas have multiple different elevations. Therefore, calculating elevation from slope will not give accurate measurements. And there is a corneal tomography. And there is no doubt that now these devices are the gold standard in calculating the case in ectatic corneas. They have the Pentacam, the Gali lenses, the Gali from Zimmer, both use the Schwinn-Flu image technology to obtain their images. And the Oculus Pentacam has one rotating camera directly measuring the elevation and calculating the curvature. The Schwinn-Flu image devices, it's very important, but you can do two things. When using these devices, we can overcome the problem, how? Of the off-centered corneal apex of the K values. In these two figures, the first using the apex as the centration, and the second image using the pupil as a centration. This is useful because the apex might not be within the visual axis. And if we consider high Ks, from it will be underestimate the power of the lens. And these devices, which using the Schwinn film image devices, advantage in measuring the elevation of the anterior and the posterior curvature. And there is two maps generated from these devices we are going to talk about, which is the TrueNet power map and the equivalent K readings, the AKR. So there is the TrueNet power map and the equivalent K readings. The TrueNet power map will measure the refractive power of the anterior and the posterior, which is very important in ectatic corneas, because it's assigned to each of them specific refractive indices. This will put together many case readings in the area that we select and make it easier to select the case we want to use in our IOL calculations. What about the equivalent K readings? Will output the information in a way that keratometry the same K, but including the equation of the anterior and the posterior power. The AKR corrected the keratometric values measured by the tomographer and adds an error that would create using single refraction index in a sagittal map. And also it allows to evaluate the progression of the power between the two different areas and decide the case we want to use in the area we desire between 1 to 7 millimeters. When we come to the formulas, how to calculate. So due to the off-centered axis, optical measurement devices are preferred instead of the ultrasound devices. The LensStar, the OLCR devices, in combination with the Barrett-Torrey calculation, show the best corneal astigmatism prediction error compared to the PCI, which is the IOL master devices and other formulas. Dr. Deacock showed in his publication comparing the pre-installed formula in the PCI and OLCR devices that the OLCR devices in combination with the Olsen formulas had the best results for long eyes. And also another study that showing that the smallest, comparing the three formulas, which is the SRK and SRK2 and SRKT, has concluded that the SRKT2 formula might be the most accurate in mild keratoconus. Another study reviewed that suggested that the Holiday 2 formula might be accurate than the other formulas when the effective lens position is variable. Another study done by Dr. Elio and Ital, it's a retrospective study in which he operated with MICS, as he said in his talk, and inserted toric IOLs in 17 eyes of 10 patients. He reported good results using the Hofer-Q formulas in patients with average axial lengths and the SRKT formulas in longer eyes, with the last one having the best results. And we should know that there is a new generation formulas like the Barrett Universal 2 and the RBF calculator are promising, but larger studies in ectatic corneas are needed. What about the 4 generations? The 4 generations are theoretically considered and important over the previous formulas in order to calculate the IOL power in all eyes, but specifically in abnormal eyes like the ectatic corneas. The Holiday, the Holiday 2 and the Haig's, Olsen, and the Barrett are examples of this 4th generation. And the increasing number of variables in these formulas could help to improve the effective lens position calculation, which is the most important value to give a good IOL power calculation. The Holiday 2 formula created by Jack Holiday, adjusted the recommended IOL power more by factor like the axial length, the corneal power, the wide to wide, the AC depth, the lens thickness, the age, preoperative refractive data. And although it remains theoretically, it has a strong base of 3,500 patients in 35 study centers, which is a very good study. It tends to be more precise in eyes with extreme findings, and it may also prove to be more accurate when we are talking about effective lens position cases. And also the Haig's formulas requires the measured ACD value, which is challenging in some cases with a very long, deep anterior chamber depth. And the Barrett formula need lens thickness and white-to-white measurements. There are publications that suggest that the Holiday 2 formulas to be more accurate than other formulas when effective lens position is variable. And the newer generation formulas like the Barrett Universal 2 and the RBF calculation is promising. So this is a very good study done in Iran. It was a very huge study and done in a very big amount of patients. In this study, they compared the accuracy of 4 widely used IOL power calculation formulas, namely the Haig's, the Holiday 1, Hofer Q, and SRK-T formulas in steep corneas. They resumed that there were no statistically significant difference between the accuracy in the formulas. However, the percentage of the eye within plus 0.5 diopters of the target reflection with higher in IOL power selection based on the SRK-T formulas. So when we think about if there is a mild or advanced keratoconus, when it's a mild keratoconus, I will going to use the SRK-2 formulas may provide an IOL power more accurately than the other formulas. And the SRK-T formula give more accurate result in myopic eyes in comparison to the SRK-2. But in other stages of keratoconus, the SRK-2 formula show the most reliable outcomes in all stages of keratoconus, although the reliability was less in severe stages of keratoconus. Indeed, none of the formulas offer good predictability in advanced keratoconus, which is no formulas giving the best till now. In these cases, the target postoperative refraction 1 diopter could be considered. So if you put a scheme for the calculation, if the corneal power is less than 47 diopter, the Holiday 2 formula within the double K adjustment, or the Hofer Q if the adjustment is not available. When in between 47 and 50 diopters, the SRK-T formulas with the target reflection of 1.5 diopter. But if it's more than 50 diopters, there is none of the formulas seem to have a good accuracy, and only recommendation could be probably not to use the actual corneal power. So use the standard case values, which is a 43.25 diopter with a mean target refraction of 1.8 diopters. When we choose the IOL option, the mostly used is the monofocal, but with the new generations of the formulas and the machines, the toric IOLs are becoming the more popular option, but we have to know that the higher the astigmatism in ectatic corneas, we will be debulking the patient, but not canceling 100%. So I'm going to give useful guidance tips for more reliable IOL power calculation in keratoconus patients during cataract surgery. So before performing any surgical operation on an eye with a stabilized keratoconus, make sure the stability of the disease progress and the stage of keratoconus. Appropriate patient selection and the comprehensive preoperative evaluation of the cornea stability is of greatest importance for assessing patients with concomitant cataract and keratoconus. Performing minimally invasive and operation is ideal in
I think we lost his connection. Shikha, did we lose his connection?
Yeah, it looks
No,
like
the screen.
Screen is
No, Dr. Armiya, it's showing that he's there,
But his screen is
But yeah.
Frozen.
I think he lost his connection.
Yes, ma'am.
Yeah.
Okay.
Shikha, some questions here before he connects again.
Yes, I think we'll go to the. Yeah, he's written that he's lost the connection. We'll go to the next part till he joins.
Yeah.
Yeah. So now we'll come to. Am I sharing my screen, Mamta?
We are seeing you, not your screen.
Okay. Okay.
Yeah.
So now.
Yeah, we can see.
So now we've come to the interesting case situation competition winners announcement. We've called for some abstracts regarding interesting situations pertaining to today's topic, that is the right IOL. When you face something very peculiar, and we had good number of submissions, and now it's time to announce the winners. And the winners are Dr. Kiranjeet Singh from Daljit Singh Eye Hospital, Dr. Manish Bapai from Bapai Eye Hospital, and Dr. Nirupma Kasturi from Jipmer Pondicherry. And we will also see now the videos that have won the competition. So I think we'll begin with Manish's video. Dr. Manish, are you there with us? Mohan, can you play Dr. Manish's video?
Okay, ma'am.
Do I go through the whole presentation? It is 4, 5 slides, or just the video?
Video. You can tell us about the case, and we'll.
Okay. So this was a patient in her 70s, and she had very dense cataract in her right eye and moderate cataract in her left eye. Her vision in right eye was, I think, hand movements or counting finger half meter. She was very adamant on having multifocal IOL. Her optical biometry was done with IOL Master 700, and I could not get her readings for axial length in the right eye, while in the left eye she had a IOL power of 19 diopters. So we did immersion A scan, and it was repeated at 4 different occasions. I could see the fundus. It was slightly fundus in the sense I could see that retina was on. There was some amount of tessellation was there. After repeating the IOL power calculation at 4 different occasions with immersion technique by our experienced optometrist and myself, we got IOL power of 4 diopters. So initially we operated on her left eye with telling her that there is a possibility of a refractive surprise in the right eye, and she had good visual outcome in the left eye. Then I took her up for right eye cataract surgery and put bifocal IOL, and she had +8 diopters of refractive surprise. So then I had to take her up for IOL, IOL removal and IOL replacement. So that is where the video can come in. Can you play video, please? Okay, so this was a well-centered IOL, as we can see initially. So the capsular bag was opened. This was about 10 days following cataract surgery. The initial surgery, the IOL was dialed onto the iris, and the haptics were placed in horizontal media. Lots of dispersive viscoelastic was used throughout the procedure to protect the corneal endothelium. And then Vana Caesar was used, and the dialer was used to adjust the position of IOL while it was bisected into two halves using Vanna scissor. Then the halves were aligned, IOL pieces were aligned to the tunnel. Initial tunnel was slightly enlarged, and then the IOL pieces were removed. Was the smaller piece, then the larger one. New multifocal IOL, which was again was injected in the bag, and the tunnel was sutured, and then OVD cleanup was done. This IOL calculation was done using pseudophakic mode on IOL Master 700, and patient had 6x6 N6 vision in both eyes 1 week post-operative. So the challenge was to not to damage the capsular bag, not to cause any iris pigment dispersion, and to maintain integrity of the corneal tunnel, since the patient was having this multifocal IOL in the eye. So this was a interesting scenario that I had to face. The question was, is it that the very dense nuclei sometimes cause falsification of axial length by when we are using ultrasound biometry in such a case?
It was almost an answer to one of the panel questions, right? We were discussing,
Yes.
unless you have the...
I think the same thing Dr. Richard had said, that in IOL Master, there's hardly a chance that 95% we get an accurate 97.
Yes.
So we get
Yeah, he had said 97.
exit length. So there's not a...
Wonderful video, but Manish, yes, you've done the surgery very neatly. Any comments from the panel?
If I could just make a comment, Shikha.
Bhaskar. Yeah, sure, Bhaskar.
The only thing
the session is yours.
The only thing here is I would probably go back to the history of the patient just to see if there is so much of a difference in the IOL power 19 and 4, and the patient has no history of having worn contact lenses or anything of that sort. That probably tells us that something which is not fitting into sync with our IOL calculation. Maybe I would have said do a cataract surgery and then take the patient up the next day if I want to be absolutely certain of my IOL calculations, and put the IOL as on day one. If Manish has aura, then he can probably do it intra.
I don't have it. I did do ultrasound preoperatively, and there was no significant axial length difference, but the immersion readings were so consistent, so that kind of got me confused whether I should stick to 4 diopters, and I put +5 diopters because that is the least powered IOL which is there. This patient has been operated a couple of years back.
Manish, what was the power of the second lens that you put in to replace the first one?
It was 19 diopters, sir. The left eye, the other eye was also 19 diopters, and this eye was 19.5 diopters.
Because the difference between the two eyes is rarely very big.
Yes.
And unless there's any history of the patient having had one very myopic eye before they develop cataract, I think it's very unlikely that you would actually get this scenario.
Absolutely. So my question to you is, sir, is whether the very dense nucleus in ultrasound biometry, does it cause falsification like silicone oil would do? Is it?
No.
Sorry?
It shouldn't do, no.
Okay.
Yeah. The other thing I would say is you need to get yourself some better scissors for cutting up the lens.
Okay.
Using Vanna scissors is not great. The Pakajang scissors and lens holder that come from MST, and I have no financial interest, are beautiful instruments, and they will not enable you not just to cut the lens in half, but to cut it into thirds so that you can take it out through a small incision.
Okay. I would take it. I'll go for it next.
Are you muted?
Yeah.
just wanted to reiterate what Dr. Richard said in the sense that these instruments are available from Epsilon also, no financial interest and very affordable. And essentially the scissors are serrated scissors, and you also get a lens holding forceps which goes through a side port, and you can cut the scissors. Even 1/4 of the cutting is enough. And by using a hand maneuver, you can roll these lenses out. But as far as the initial error in the IOL power calculation itself is concerned, it's really an enigma. I don't think when you're doing a A-scan biometry, immersion A-scan, the density of the cataract really matters as far as the IOL power is concerned. And I do not know how you got this such a large difference. If it was a highly myopic eye, maybe a posterior staphyloma is what I would consider, but you obviously put in a plus 19 diopter lenses, so maybe that's not a concern.
I repeated it was immersion ultrasound scan, and I repeated it at 4 different occasions before putting the lens. So really enigma, as you said, as to why such a difference would come.
Anyway,
but subsequently on a pseudophakic mode, you got the correct.
Yes,
Yeah.
yes, I did.
I have a question here to the panelists. When we are talking about these IOL exchange, is there a time frame that you think that we won't be able to do an in-the-bag replacement? If we are seeing a Rexis, let's say 5 years, 4 years, 2 years. If you see a regular Rexis and a multifocal IOL in the bag, and we are thinking of an exchange, I would like to know, is there a time frame besides that you would see that maybe we are not able to put it in the bag now, or the anterior capsule would be fused and we won't be able to extend it?
The trick here is very simple. In order to open up the bag, what you do is to get your viscoelastic syringe, and instead of having a blunt cannula, you put on a 26 gauge needle and you turn it bevel down. And with the bevel down, you can insinuate the edge underneath the edge of any capsulotomy by a very small amount, just a fraction of the length, and then inject a small amount of viscoelastic. That will lift it up sufficiently. You then take it out of the eye, put a blunt cannula on, and then go into the place where you just lifted up the capsule, and then it will come away from the lens without any problem.
The haptics won't be fused at any point.
That's a different issue. That's a different issue. It depends entirely on what sort of lens. So for example, if it is an Acrisoft lens, the little bulbs on the end of those haptics can get fused inside the capsule when it constricts. The haptics on the Symphony or the Technis lens, because they are smoother, will tend not to do that. But until you get into the eye, you don't know. The important thing is to use a viscoelastic, which is going to be able to force the capsular bag open so that you can get the best possible option. If you do that, once you open up the bag as much as possible, you take an instrument and see if the lens will rotate. If it does, then you're home free. You don't have a problem. If it doesn't, then you have to try and work out why it doesn't, and you may have to try and manipulate it out of the position where you actually find the lens. And I say different lenses behave differently, so there's no hard and fast rule here.
Sure.
I think as far as the hydrophilic lenses, if it is a hydrophilic material, then taking out these lenses even years later is fairly easy. If it's only hydrophobic lenses, then because of the tackiness of the material, and if the surgery initially that has been done is very good, where you have got a very regular Rexis overlap onto the optics of the lens, then it becomes a bit of a challenge. And these are the instances where all this visco dissection that Dr. Richard elaborated on might become necessary. And some of these lenses, you might be able to mobilize the optics, but the haptics are stuck. In these cases, it might even be a good idea to just snip off the haptics and just remove the optic alone and go ahead and implant to a secondary implant. But in some cases, which is extremely difficult, maybe especially if it's a hyperopic refractive error that you have, this is a situation where a piggyback lens might be a better option rather than trying to extricate a lens which has been there for many years.
I agree. It depends on what the reason is for you taking it out. It seems unusual 5 years down the track that you would actually have a patient that was worried about the refractive error. I mean, I would find that very strange because you would have dealt with it a long time before.
Probably that
Strange.
only for pediatric patients.
Yeah. Pediatric cataract surgeries, post surgeries, myopic shift, we may have a situation like this.
But then I would use a piggyback.
This was exactly the situation.
Yeah, I mean,
this was exactly.
Yeah, is if you're going to put a multifocals into pediatric patients, if you use the Rayner setup, whereby you actually have the multifocal in the sulcus, then you can go on changing the lens endlessly as the patient grows up.
Sulcoplex?
Yeah.
Sulcoplex.
Yeah, they do a trifocal sulcoplex.
I think we'll finish Dr. Armia's talk.
Dr. Armia is here. I don't know whether he finished his slides.
No, I think he's again lost connection. Okay, then we'll move to, we'll move to Dr. Kiranjeet's video. Mon, can you play? Or would you be sharing your screen, Dr. Kiranjeet?
I would be sharing my screen.
Okay, now Dr. Armia is there. So what we'll do is, Dr. Armia, since the panel discussion is after this, we'll play two videos, the winners videos, and then we'll take your, we'll continue with your talk and then go on to the panel discussion.
Can I start?
Yes, please.
So my talk is on is concerning toric IOL, toric IOL implantation in a case of traumatic iris defect. But my focus is going to be on the iris repair with the help of iris prosthesis, which I have created very lately. If you just implant a premium lens and you don't deal with the iris defect, the patient is going to have problems with the vision. And the usual modalities available are the iris segments inside the capsular bag or in the sulcus or the single pass 4-throw pupilloplasty. But this one is implanted at the plane of the iris. So this patient had a nail injury at the limbus with loss of iris tissue and a traumatic cataract also, and a cylindrical error of 6 diopters. So here it goes. So you can see the traumatic coloboma. So the patient came with a lot of discharge. I took the readings for the toric IOL, sent the patient back home, and the next time when the patient came, the IOL was already there. So did the markings. The cataract was quite soft because the patient was just 25 years old, and removing the cataract was not a problem. The problem was basically that missing iris. The patient is going to have photophobia post-operatively, and he is going to come to me again and again. So this cataract part is very easy, and I'm using a toric lens which has a serrated haptic. So when I put inside the capsular bag, it is not going to rotate back or forth. So to be very honest, this is my first toric IOL, and the patient belonged to a very poor socioeconomic status. That is why I could try something new on him. So very easily the lens is rotated. You can see the markings. And after that, you will just see the iris prosthesis. I put a little bit of pilocarpine carbachol, and then I bring in the iris prosthesis. This iris prosthesis is made on the, it is made up of PMMA. It is opaque. It is made on the platform of iris claw lens. And this thing is dedicated to Dr. Jan Wurst. And simply, this lens is pushed behind the iris, held with a Clayman forceps, And with the help of a 26 gauge needle or a cannula, just push the iris back in the claw. So one side is fixed. Similarly, changing hands and changing the instruments, I do the inclination on the other side also. And the haptics of this device are visible in the this pupillary area, and we are going to redesign it, that is for sure. And this thing is fixed in a flash. Viscoelastic is removed. And patient comes to me in the OPD after 2 hours. I get his refraction done. It is uncorrected 6/6. And then I take him out in the sun and tell him to stand in front of the sun, and both eyes are opening just the same. That is all. Thank you very much.
You will have to stop sharing the screen.
Okay. Stop.
Yeah, very nice video. Any comments from the panel?
Well, it's certainly a novel way of dealing with the segment. I've only ever used the ones in the capsular bag. I haven't seen this one before. I think you're right. It needs a bit of redesign to make it not quite so near the center as far as the pupil is concerned. Also, I suspect you might need a range of different colors as well.
Yeah. We have ordered different colors, and in future we are going to take care that those haptics, they don't come into the pupil area.
Very innovative idea and design, Dr. Kiranjit. I mean, as you said, slight modifications may be necessary. But now this single pass 4-throw pupilloplasty is gaining prominence, and in a situation like this, it would have been fairly easy to perform. I mean, there has been some loss of tissue. I mean, how do you think? Because the cosmetic effect of that might have been slightly better than this. Why do you prefer this?
Yeah. Sir, the thing is, with a single pass 4-throw pupilloplasty, I'll have to suture twice in that area, and what I'll get is I'll get a slit out of the pupil, a very thin slit, and then I'll have to take a vitractor. Then I have to create a opening in the center, and I'll be disturbing the blood aqueous barrier. I could be creating inflammation in the eye. And it is going to be very small opening, 1.75, 2.0 millimeter. And in this case, the rest of the pupil is reacting. Only the part where I have implanted the device, that is where the opaque thing has come into play. And rest of the thing is opening up. It is doing that pupil reaction is there. If I need to do a fundus examination, I can do that after dilatation. So I feel this is less traumatic than a single pass 4-throw pupilloplasty.
Maybe in the back prosthesis has been there for a long time. Now it's a novel idea of iris clip prosthesis.
Yeah.
Fine. We'll play the final video, Dr. Nirupma Kasturi's video. Mohan, can you play the video? Nirupma, would you like to tell us about your case briefly?
Yes, ma'am. Good evening, everybody. I am Dr. Nirupama from JIPMA. My case is that of a 23-year-old female who presented with total cataract in her left eye. And on examination, she had a bilateral microphthalmos with microcornea. And the right eye had a clear lens and the left eye had a total cataract. And on biometry, the axial length was less than 20 millimeters in both eyes. And the corneal diameter was 9 millimeter horizontally and 8.5 millimeter vertically. And we calculated the IOL power to be around plus 27 diopters. So the steep cornea had actually compensated for the axial hyperopia. And the IOL power was plus 27. But our dilemma was whether to use the routine foldable IOL or to go for the customized undersized IOL. And we didn't get enough literature actually to decide on the in the bag sizing of the IOL. But because it was less than 9 millimeter, we ordered a customized micro lens from IOCare India, and that was implanted successfully in the bag. So you can share the video, ma'am. I'll just explain the steps of the surgery as well.
Mr. Mohan, can we? Yeah.
Yes, so in microphthalmos with microcornea, it is easier to do the cataract surgery with small incisions. So, because it was a young patient, we didn't expect a hard nucleus. It was a relatively soft nucleus. So I could do a bimanual lens aspiration, just like how we do in pediatric cataracts. So the capsule was stained with trypan blue, and we did the rhexis with the micro rhexis forceps through the side port. Although there are some studies, especially by Dr. Coker and all, who have advised doing a scleral tunnel incision for cataract surgery in microcornea eyes. And he says that even the surgically induced astigmatism and corneal opacity is less, and the approach and the space to operate is better. But I could manage to do the surgery with bimanual lens aspiration. Although the small central nucleus could not be aspirated, so it was actually expressed out using hydroexpression. And then this was the micro lens which we customized, which is actually a 4 millimeter optic and 9.5 millimeter overall diameter. And using the routine cartridge, it could be implanted in the bag. After that, we wash the antechamber, and it is also important to close the wound. So I sutured the main incision with 10-0 nylon. And post-operatively, the patient had a 6/12 vision on the first post-op day, and she's yet to come for the best corrected vision on the last follow-up. So my dilemma was how to decide on the IOL size, because sometimes I come across children with ophthalmos as well who require cataract surgery. So can we use the routine sizing of the IOL, or how do we decide on that?
Can I ask you, that lens, was that a Fresnel optic?
Pardon, sir?
Was that a Fresnel optic? Because it had, it looked like a diffractive lens.
No, sir. It was actually a monofocal IOL only.
Yeah, but it was a Fresnel optic.
I'm not sure because I didn't check on the manufacturing details.
Well, you can see it on the, you could see it on the video.
Yes, sir.
That was one of the reasons why it was so thin, because they were able to get the optic wouldn't need to be thick. I mean, in an optic that size, for a 27 diopter, it's going to be very difficult to fold because it's going to be relatively thick. You can make it thinner by making it a Fresnel optic, and that's obviously what they did there. So
Yes.
This is why I was asking you the question.
Yes, sir. Actually, they had a difficulty and they had to redevelop it. So it took some time.
Because the Zeiss used to have their extreme range, which went up to 60 diopters, and they used a Fresnel optic in order to be able to do that. So that even 60 diopters, the central thickness was the equivalent of about a plus 24 biconvex lens.
Yes, sir. But some authors have managed to use the 6 mm optic with 12 mm haptic in microcornea eyes. So is it all right, or should we try
No, it's
to?
fine. I mean, if you can get them in and fold them, that's fine. I don't see any reason that there should be a problem. But this eye was particularly small, and you'd ordered the special lens, so that's fine. I think if you are going to use a standard lens, then something that has relatively soft haptics, like an IQ lens from Alcon, would be the way to go, because even though the inside of the eye is very small, those haptics will go up against the optic and in the bag without any problem.
Right.
I think you have a very relevant question, Dr. Nirupama, in the sense that, what would be the size of the overall diameter that you will decide on? Most often we come across corneal diameters about 10 to 11, and the overall diameter of the normal lenses that we implant is 13 to 13.5 millimeters. So basically, the lenses that we implant are larger than the corneal diameter because the overall back size is slightly larger, and the lens also compresses itself and fits it to the back. So slightly larger, if supposing the overall diameter of the corneal diameter was about 9.5 or 10, even a normal lens could have fitted in. But in your case, since the cornea was somewhat smaller, I would have rather gone for something like 11 millimeter because, of course, rotational stability was not a concern here because it's not a toric lens that you are implanting. But maybe the overall diameter of 9.5 for a 9 millimeter cornea is somewhat... what is the corneal diameter you mentioned?
Yes, sir. The horizontal was 9 and vertical was 8.5.
So I might have gone more for something like a 10.5 or 11 millimeters. Absolutely empirical. It's just because, normally we have about 10 to 11 millimeters and we implant a 13 or a 13.5 millimeters.
Yes.
And just to share this information with you, I have seen presentations where in more extreme degrees of microphthalmos, just the haptics was completely cut off and the optic alone was implanted. That was in situations where you have about a 7.5 millimeter overall diameter. So just leaving the optic alone inside the bag also has worked. Kumar Doctor has shown this video.
Thank you, sir. Thank you, sir.
I think with that, we'll finish Dr. Armia's talk. Please share your screen. Dr.
Yes,
Armia.
I don't know
How
where
many
we...
slides are-
I don't know where we were. Which slides we?
You are basically giving your this thing on
This one. It was this one, yeah.
Yes.
Okay.
Yes.
Okay. So continue my useful guidelines. It is a recommendation to consider using a standard 3.25 diopter for severe keratoconus, and also the SRK2 formulas may provide the most accurate IOL power in mild keratoconus. I'm going to share one case of it's a female patient, 60 years old, done penetrating keratoplasty since 20 years for keratoconus, and has now a nuclear cataract grade 3 to 4. But she has a 9.6 diopter astigmatism. And we decided with the patient to correct some of her astigmatism, around 5 diopter, using the high toric T9 from Alcon. So I did the calculation through the Barrett formula, and as you can see, it's 9.6 diopter astigmatism. And in these cases, you should put the IOL in the perfect. There is no place for rotation and misalignment. You still on me? Yes, use me. So the postoperative refraction for this patient was 0.5. Best corrected was 0.5 with the residual 4 diopter astigmatism. So can you see the video now? Hello?
We can see the video, sir.
Okay. So I'm going to run it. So as you see, this is the penetrating keratoplasty, and there is a small tips in these cases. First, the 2% away from this line, because this is a very weak line with the weak desmids. If you entangle this line, you are going to have a desmid rupture. So the most important. The second most important in these very long cases of PKP, that the anterior count is already decreasing. So the cohesive and dispersive viscoelastic bias, it must be done. You put a dispersive then under cohesive. And also the wound should be in the steep meridian, as I did. The most important, another tip, that the rexus must be central and a very good size to decrease the rotation and the displacement of this very high toric IOL. This is very important to take your time in your good rexus, central. Always keep protecting the endothelium in these cases, because this is a very long-standing penetrating keratoplasty and the number of cells is already decreasing. So as much as you can do shopping and decreasing the size of the nucleus, you are going to have the benefit for protecting the endothelium and lessen the phaco power. As you can see, the penetrating keratoplasty is about 9 millimeter in diameter. So with the Centurion, I can do this. So my technique is stop and shop, dividing the nucleus as much as I can. After I finish the first half, injecting more and more visco dispersive, protecting a lot the cornea endothelium. This is very important. And take your time, don't be in a hurry, decreasing your phaco power, increasing your vacuum, and no hurry in these cases, because you want to decrease as much as you can the phaco power and time. And as I finished, very important, after you remove your cortex, injecting a lot of viscocohesive in the bag to inflate the bag as much as you can, because in these cases, the posterior capsule little bit redundant, because this is very old. And you want to put your toric IOL in the best way with no rotation. When you put your high toric, this is a T9, this is a very high toric IOL. So you need to put it in the perfect alignment. And you do this, you should remove all the viscoelastic behind the IOL to give the negative energy for these hydrophobic lenses to be in closed contact with the posterior capsule. And this will decrease as much as the rotation of this IOL. And you see, after I finish the hydration of these, is how the marking is alignment with this high in this very critical and crucial stages. We corrected as much as I can from the toric, and I left about 4 diopter astigmatism. So ending with my conclusion, in keratoconic eyes, optimizing the IOL power calculation is certainly a vital importance to the improvement of surgical outcomes and ultimately patient satisfaction. Keratoconus can cause multiple sources of keratometry and biometric errors, especially in severe cases. And to obtain the best outcomes, surgeon must take an extra time to address the complexities of the cornea, utilize the best technology available, and make careful preoperative measurement, adjust the refractive target based on the calculation made with formulas, the multiple formulas, and have a plan to place to address the refractive surprises. Thank you for listening. Thank you so much. And sorry for the internet disconnection.
Thank you so
Thank
much.
you. That was
oh, sorry, Shikha, you want to continue?
No, you may.
Oh, okay. So that was very interesting. Toric IOLs, steep corneas. I think we can go on and on in this kind of a topic, because there are so many situations where we think about toric IOLs, but then we have to just decide whether we reduce the astigmatism or we completely nullify. I recently actually would like to share a case here, because that was the thing which crossed my mind. I had a case with Alport syndrome, a young 23-year-old man with, one eye had a -16 diopters of myopia with some astigmatism, and the other eye has -6. And the best corrected visual acuity improves to only 612. Even with the potential acuity meter, we could improve 612 in one and 612 parts in the other eye. So I actually thought that there was lenticular astigmatism, and it was a lenticular cone, both on the anterior surface and the posterior surface. So I had this thing in my mind, what are we talking about premium IOLs in these cases? If we have this kind of a situation, I do see 2 reports in the literature.
We have Dr. Alio again with us.
Yeah, so I thought this is the best forum where I should ask now what should we do in this kind of a situation. He doesn't have much. He has a corneal astigmatism of -2.5 in his right eye, but the other eye doesn't show much corneal astigmatism. So this was all the lenticular astigmatism, which I thought he has in both eyes, one more than the other.
So he has a posterior lenticonus?
Yeah, he has anterior lenticonus, but on ASOCT, we could still see a bulge, a touch of bulge in one eye on the posterior surface also. I wish I could show pictures actually here.
Axial length?
Axial length is 23.1 in both eyes. Axial length was normal.
I have some experience in posterior lenticonus. Usually it's unilateral, and usually sometimes it comes with an open posterior capsule already open, and some with a opacified posterior lenticonus. If it's just opacified posterior lenticonus, you can do a very good posterior excess, and you can implant your toric inside the back. But some of them, I work on a lot of posterior lenticonus. When I remove the nucleus, I found that the posterior capsule is already opened. I can't repair it to a continuous circle case. In this case, it is very difficult to put a toric IOL.
Dr. Richard, can we have your opinion too here?
Yeah, first of all, did this patient have stereopsis?
No, I would say no, because we did that. And because he was 618 and 612 in this eye, the best corrected, he did not say that he could hear. The stereopsis wasn't very clear.
I mean, because one thing you could do here, which as he doesn't have stereopsis, is actually to just give him monovision, because he's not going to get any interference between the two eyes because they don't work together anyway.
So we would just think about.
You could probably get away with 2.5 diopters difference to give a reading eye and a distance eye.
Do you do a DBR?
Bhaskar?
Or did you do a DBR? What did it show? The IOL power and all that?
Sorry?
The biometry. Did you do the biometry and what did it show?
Yes, biometry, the axial length, I said 23 point.
The power, what is the IOL power?
And the power was 19 and 19.5, which is like the Techness monofocal lens.
So there was no significant cylinder that was shown?
The cylinder is in one eye. Actually, the eye with -16 did not have much cylinder. I think if I remember it right, it was 0.5. But the other eye with a -6 myopia had -0.25 cylinder.
So basically, biometry did not show any cylinder.
Sorry?
Biometry did not show any significant cylinder, so he did not require a toric lens.
2.5
No, one eye shows significant cylinder plus 2.5 cylinder, but one eye doesn't show significant cylinder.
What's
the eye with a high myopia does not show significant cylinder.
What's the axis of the cylinder, Mamta? Is it a regular astigmatism with the rule? Because that
I think I won't be able to tell that because I don't remember that.
I could.
Bhaskar,
So basically, when you're looking at lenticonus, you're basically looking at a lenticular myopia. It's not something with respect to the cornea or the axial length. Your lens is deep in the center, which could, if it is bang in the center, you will get a more myopic component. If it is slightly off center, you will get an astigmatic component in your refraction. Your vision will not improve beyond a certain level because you have a dysfunctional lens index, which is causing the vision to be poor. There, the only option for a refractive correction would be taking care of the lens because that is abnormal, so you remove it. Issue with premium lenses would be only with respect to your toric lenses would be if you have a corneal astigmatism, yes, you can go ahead and do a toric lens, provided your posterior lenticonus component doesn't blow out and you are able to stabilize the lens in the back or do an optic capture or do a sulcus fixated like a plate haptic toric lens in the sulcus, which would also be an option if at all the patient is very keen. But I would probably think doing a normal lens or a toric lens in the back, and if there is or if you have a PCR and you cannot put a toric lens, just do a normal lens and do a PRK on the surface for that residual 2.5 or 3 diopters astigmatism will also work. Premium lenses, there are issues with macular changes also with Alport syndrome. So I would probably be a little bit concerned with putting in a multifocal lens in these patients.
Dr. Aliu?
Oh, Dr. Aliu is there.
You're muted. Muted.
Okay,
You're
you're
muted,
muted.
Dr. Aliu.
Thank you. Thank you for this opportunity again. Anterior lenticonus is not a problem for a premium lens of any type, as far as the patient is not amblyopic, because some of these patients, because of the long-standing presence in the visual axis of an opacity, they don't develop good macular function. So I do in these cases the macular function test. Macular function test was invented by Jerome Briggen. Is you have with a plus 8 a chart that can be sent free of cost to you by Dr. Briggen, and then you check in a very reliable way which is the macular function. Based on that, if the macular function is normal, I proceed with no doubt, because it's a young person usually, with a multifocal lens of the type that I select depending on the patient needs, personality, etc., as I mentioned before. But if you have a posterior lenticonus, it's different, because these cases very seldomly end in a happy end. Most of them end in a casual disruption. Not always you can do a CCC, posterior CCC, and you have to have either a backup with a monofocal lens, as Richard has mentioned, targeting a -1 or -1.5 better, or you are facing a problem in case that you are not prepared for a plan B, as far as posterior casual disruption, if not properly managed, will not allow you in many cases to use your lens, and definitely not a CTR. So I have in these cases my plan A with a multifocal that I decide to use, no CTR in these cases, and plan B monofocal with a disparity of 1.5 diopters with the dominant eye, just to get more vision, as rightly has been pointed out by Richard. I think that this is the best option, because sulcus lenses for multifocals, believe me, do not work well. I have abandoned them time ago.
Thank you so much, Professor Aliu. That really helps, actually. And let's plan the surgery next. Shikha, to you. Want to add something?
Yeah, just a few. These are the last set of questions from the audience, and with that, am I sharing the screen?
Yeah, you're sharing.
Yeah. So for this session, these are, you can read out the questions, Mamta.
For the last session, we had some set of questions. Is aberrometry necessary when we use an aspheric lens, or will wrong asphericity worsen vision? How do we do a toric alignment without a bubble marker? And then probably we can take these questions. Are silicone IOLs still better than hydrophobic lenses? And how about IOL calculation in a patient who's had refractive surgery? I think we've discussed these questions, biometry in premium IOLs in detail. And let us have some word about astigmatism and corneal incisions. What do you think, Shikha?
Yeah, I think, in this session, astigmatism and management of astigmatism, we can cover the questions relevant to that.
Yeah.
There was a question in between. You said Kavita was asking. I think you said we'll be dealing it with later.
For corneal traumatic astigmatism, if it is stable,
whether toric IOLs is an option, or LRIs, or where is the place of LRI in all these special situations, or LRI anywhere compared to toric IOLs?
Yeah, so that was my question.
Okay, can I say about this part? The traumatic corneal scarring.
Yes.
It depends on how deep is the cornea scar. Is it central or paracentral?
Paracentral, enough to be off visual axis, but enough to cause a significant astigmatism.
Okay, so how deep is the corneal scar? Usually I do anterior OCT to decide how deep is the scar. If I can ablate like a PTK to regulate the cornea first, then give the patient time to heal and you take a good alignment of the cornea, this will be better if the scar is within 100 micron of the cornea. If it's deep scar, paracentral, so toric IOL could be an option, and LRI another option. You can put in monofocal IOL, and you do an LRI. This is my opinion.
So ideally, a toric IOL should be used when the astigmatism is regular and orthogonal, that is at 90 degrees to each other. Whenever you're dealing with irregular astigmatism, it's a relative contraindication. And as far as usage of toric intraocular lenses in corneal scars and mainly in keratoconus is concerned, I think the centration of the cone is extremely important. If it's a well-centered cone, if it's a stable cone, you could consider toric intraocular lenses to debulk. But if it's a decentered cone, and decentration we judge by looking at the nipple of the cone in the posterior corneal floor, and if it's outside the central 3 millimeter, then that's a significant decentration. In these cases, putting in a toric intraocular lens would not be a good idea, because in that case, you would get the axis of your intraocular lens and the cornea would not be in line, and the patients will not be quite happy. And in case they had been earlier using semi-soft lenses or rose-scale lenses or scleral contact lenses for correction, once you have put a toric intraocular lens in these cases, the usage of these lenses would become would not be possible. So you might end up with fairly difficult patients, fairly unsatisfied patients. So extremely important, if the patient had been reasonably happy with spectacle correction of the toricity earlier, you could consider toric intraocular lenses. But if they required rigid contact lenses for the correction of the toricity, then it's not a good idea to put in a toric intraocular lenses in these cases. Now, as far as the incisions itself is concerned, I think today we have completely given up the idea of on-axis or making incision on the steeper axis, because nowadays what we consider the centroid value of the astigmatism is surgically induced astigmatism, which for a 2.4 millimeter incision is just about 0.1 diopter. So essentially, I do all my incisions with temporal clear corneal incision. The role of LRI is less than 0.75 diopters of astigmatism, maybe paired LRIs nowadays, especially with the digital imaging systems like the Vivior, where you get an accuracy of your incisions is there. You could use them, but no way are they predictable as the toric intraocular lenses. So whenever there's significant astigmatism, it would be the toric intraocular lenses would be the way to go. The other option that's talked about is the OCCI or opposite clear corneal incision. So obviously, when no instrument goes in, and it's just a 2.4 or 2.8 millimeter nasal incision, I think that's done more for the surgeon satisfaction rather than any significant potential benefit for the patient. So significant astigmatism, go with toric intraocular lenses, but maybe, especially when you're doing multifocal intraocular lenses have less than a 0.75 diopters of astigmatism, throwing in a couple of LRIs to debulk the astigmatism might be a good idea.
So debulking, the role of LRI probably is limited to debulking the astigmatism.
But the results are unpredictable. You don't know how long the effect is going to last, when the effect is going to come back, wear off, and the astigmatism is going to be back.
And pinhole papilleplasty play a good role in this high irregular astigmatism. I tried a lot in severe high irregular astigmatism in keratoconus, and when you make the pupil around 1.5 to 2 millimeter, it can correct a lot of the abrasions from this high irregular astigmatism.
Bhaskar, would you like to add about the multifocality given by the cone?
So basically, when you're looking at keratoconus, like what Dr. Ramamurthy said, it's important to know what the patient was happy with, whether the patient was happy with the glasses before undergoing cataract surgery, and the stability of the cone, as was already mentioned. Luckily, most of the time that we are going to be doing cataract surgery is going to be around 50-ish. So you would expect the cone to be stable, but that doesn't give a guarantee. Now, when you're looking at a cornea which is steeper, say more in the inferior portion, they normally have a multifocal cornea. So even if you aim for, say, a plano, you might actually be surprised to see them reading 6.6 for distance and reading N6 for near, because the multifocal cornea behaves as a multifocal lens to give them a range of vision. it is so you don't actually need a multifocal lenses as far as keratoconus is concerned, because your cornea itself is multifocal. But the most important thing is how good the vision was with glasses before surgery, because if they were using contact lenses before surgery, they continue to use contact lenses post surgery for the same quality of vision, unless you're going to be doing a corneal transplant. Again, if you're going to be putting in a toric lens, especially like the case that Professor showed in a post-PK patient, if at all he develops a failure of the graft, then you have to resort to a DMEC or a DSEC, because if you're going to be doing a PK, the entire calculation of the lens goes berserk. You might have to change the lens to your standard keratometric value. So if you're putting a toric lens in a patient who's had a corneal transplant, and if it fails, it has to be a DSEC or a DMEC, or you have to change the lens subsequently when the patient undergoes a repeat transplant. So that is very important to be mentioned to the patient prior to the surgery also.
One thing we have. Yeah, I was going to say one thing.
Incisional surgery in keratoconus is totally unpredictable. You know, you have sometimes good outcomes, others you have irregular astigmatism induction. So my advice is not to use any type of incisional surgery in keratoconus. This is my point, and I don't do anything, you know. I agree with Ramamurthy that these cases that have eccentric conus many times do not behave well with a toric lens. So this is why you have to select only the toricity that is in the center of 3 millimeters, and ignore the rest, at least to decrease the amount of astigmatism. But the patient should know that correction of astigmatism in terms of metropia is not affordable. What we try is to gain vision, not to be spectacle independent. Sometimes they are spectacle independent by chance, but my target is not refraction. My target is vision, and the best vision possible obviously needs the correction of astigmatism, but not with incisions, not with relaxed incisions.
Shikha, can I ask?
You were saying. Yeah, Dr. Packard was making a comment. I interrupted.
Yeah, we have one thing we haven't mentioned here, which Jorge mentioned earlier on in his talk, would be the use of the IC8 lens, because where you have significant corneal irregularity, this gives you an option that will actually get away with a lot of these problems. The patients actually do quite well.
You know, Richard, I do agree, but the problem that I have found with this lens is lack of predictability. You know, this lens is very, very difficult to implant because it's a rigid lens. So number one, you need to open a large incision, what intrinsically will be astigmatogenic. So you are using an astigmatogenic implant. And the second, it's very difficult to explant because of the rigidity. And some cases have done well, others have not done well at all. You know, I don't know what is the key factor to predict a positive outcome with this lens, but my hands have been not that as successful as it is claimed by other surgeons.
The other alternative, of course, is to put in a standard monofocal lens and then put in a pinhole piggyback, because if it doesn't work, you can then take it out.
Yeah, the piggyback is the one from the Brazilian, from Barton, but the problem is this has a very small opening. This is 1 millimeter, you know, it's 1.2 precisely. And you know, to really be precise in the visual axis with 1.2 in the sulcus, believe me, it's not that easy. Any eccentricity will make this lens to get the patient with very sharp decrease in vision. And the explantation of this lens is a hell because it's made in a very rigid material. So while I understand and I accept that it's a new emerging topic, I would like to have a guarded opinion about this use, and I do not recommend to openly use it unless you are in a clinical study with all the warranties, because this lens still today is not clear in these indications, even that could be a useful tool in the future. But the Brazilian lens, the one from NOSEC, which is manufactured by Morcher, is difficult to centrate because the very small opening makes a difficult job for the surgeon to be in the visual axis. Really.
The other problem with the
I have this question about corneal scars when we are discussing.
Please. Yes.
Oh, no, I'm sorry. I mean, just wanted to add to what Professor Alio said, that the other problem with the IC8 lenses and these pinhole lenses would be the extremely constricted field that the patients will have subsequently, and also the amount of light that's going inside the eye is going to be significantly less. So the kind of quality of vision they have also would be a big compromise. Just for the sake of completion, as an extension, the concept of pinhole pupilloplasty has also come in, where Dr. Amar and his colleagues talk about constricting, making a very small pupil which is centered on the the vertex of the cornea, and they expect it to work. They claim it works reasonably well.
Yeah, you know,
I use it in a lot of, yes.
No. Just one thing, John. That is a very nice comment. You know, the company says that the HMI doesn't restrict the visual field, but it's not true. Not true. They use only visual fields at 30 degrees. But take your visual field at 60 degrees, you will see how the peripheral visual field, as expected, is amputated. You know, you get about 40 degrees visual field, which makes bilateral implantation is obviously impossible, but it makes the patient to have a restriction like in glaucoma. So, but look at the papers, they deny to have this complication, but look at the visual field test. They have performed at 30 degrees, while the restriction is found when you use the 60-degree visual field. So indeed, yes, you are very right. These lenses decrease the visual field, peripheral visual field.
Thank you.
There was one question by Asha, please go ahead. Go ahead.
This is in, see, we are all talking about eyes together, no? So we have situations where monocular patients, like one-eyed, or patients with strabismus who are not binocular. So is there anything we'll specially look for or do when we plan premium IOLs? Or is it like we consider as one eye separately and just plan like how we do the other cases?
You know, the answer,
Dr. Packer had made a note about stereopsis. I think we can take it from there.
Yeah.
The answer is in suppression. Kavita, Dr. Kavita. Look at, if the patient has a strong suppression, there is no problem using multifocal lenses in these patients. But if the patients don't have suppression, especially if they have any type of binocular problem, especially those that have screen with good visual acuity, they have the disparity in the fixation based in abnormal retinal correspondence. This is indeed a contraindication for multifocal lenses. So abnormal retinal correspondence is big no, you know, big no for multifocals. Good suppression is an indication.
Right.
So other consideration would be, you know, whether you'll implant a multifocal implant in a monoocular cataract, if one eye alone has a cataract. This controversy comes in. So initially it was thought that multifocals essentially has to be bilateral. But nowadays we do implant these lenses even in when the cataract is predominantly in one eye. Of course, telling the patient that as and when the cataract comes up in the second eye, it's a multifocal that has to go in. And we have quite a lot of patients who have, even after unilateral implantation of multifocal intraocular lens, are quite happy. Sometimes they don't even wear glasses, though they have some amount of refractive error in the second eye. The other situation is where a monofocal lens has been implanted much earlier, and today the patient comes in for a second eye operation, having heard about multifocal intraocular lenses. So even though you would like to put in the same type of lenses in both eyes, after a significant conversation, we have put in a multifocal lens unilaterally, and these patients have benefited from relative spectacle independence. So I think the concept that multifocals always has to be bilateral has to go away, and even a monoocular multifocal intraocular lens is okay. Stereopsis, of course, is another concern.
Yeah. You know, but this is a good field for this EDOF type 5, you know. EDOF type 5, imagine that you have in one eye the unlucky outcome to have a posterior disruption. You implant a monofocal lens because you cannot do almost anything else. In the second eye, you can use the VVT or you can use the eye hands, and the outcomes are good. I have done this in several cases, and I am astonished about the tolerance of these lenses. They do not provide any type of binocular competence and symptoms. So VVT indeed is a lens to be considered in these cases where monocular implantation has to be decided or not, depending on the clinical condition of the patient or the already operated eye. But this is that type 5 EDOF are a good option for these cases.
Great. Well taken.
There was one question by Dr. Chetan Rao, a very dear colleague from our retina department. He was asking if there are a lot of vitreous membranes. How do we calculate? How do we, any tips about the biometry? Because there are a lot of, he's a retina surgeon, there are a lot of membranes in the vitreous. Any comments from the panel?
We first remove the membranes and then do a secondary cataract surgery later.
I don't think for optical biometry it would really matter.
Optical biometry probably is the, so optical biometry is possible with the membranes, right?
No,
so
with the swept source basis, when you can get a reliable calculation of the intraocular lens axial length, even in the presence of a very hard, nearly a total cataract, membrane should not obscure this getting reliable readings.
With teams, vitreous hemorrhage also.
So optical biometry is the answer. Fine. So
I have a question here. The last question, maybe.
Sure. Yeah.
So,
we are much.
I know.
We are much behind the time, but we are having a nice time. So you may ask your last question.
Just that I was thinking about this toric IOLs and corneal scar. I wanted to have this panel's opinion. Am I right if I say that in viral keratitis, patients healed scars and also patients with PUKs, peripheral ulcerative keratitis, toric IOL is not an option? We have to put monofocal IOLs. Are we correct?
I agree. I totally agree.
You agree?
I don't agree too.
You don't agree?
No, you said viral keratitis with superficial corneal scars, which are healed.
Viral keratitis, which you have treated for last couple of years now, has cataract and has significant astigmatism. Would you consider a toric IOL in this case? In another situation is a PUK.
Oh, the two concerns I would have is the potential for vision in this particular patient and how exactly is the toricity. It's, it's ideally toric lenses should be, as I mentioned, should be placed when the astigmatism is orthogonal, where the steep and the flat axis are well defined or at 90 degrees to each other. If it's a grossly irregular astigmatism, if it's all over the place, and essentially there are a lot of aberrations, obviously, irrespective of what is the cause of the astigmatism, you would stay away from a toric intraocular lens. But if it's a well-centered astigmatism and you get the axes which are nearly at 90 degrees to each other, I do not see, if it's supposing a peripheral corneal scar, then I don't see why you should not be using it.
But
it's
my
a
question
recurrent
is,
disease.
it's a recurrent disease.
Viral keratitis is a recurrent disease.
Recurrent disease. And PUKs are also recurrent. So what if we have a recurrence there?
So
the problem is of recurrence.
The problem is the recurrence. So these are like unpredictable things. So maybe because this was a question which came up and my resident asked me and I was thinking, probably we should not think of a toric IOL. So what if you have a recurrence here?
I place the lens and pass it on to my cornea colleagues.
So actually, toric IOLs are pretty safe.
But fortunately, it's my patient and I have to deal with it, being a cornea person then.
Yeah. We recently published a paper, a review about the herpetic eye disease, and ocular surgery. You can read it with my name. It's herpetic eye problem and ocular surgery. And, we have indeed a problem. I don't know if in India you have as many cases as we do have in Europe, but herpetic eye disease is a real challenge for vision of the patient long life, along all his life. So with this in mind, to use toric lenses in scars which are caused by herpetic eye disease, in my opinion, is questionable because, as you rightly point out, these patients will have relapses and will have less vision, and probably the astigmatism will change and the refraction in global. It is not a clear indication. It's really a case that has very silent herpetic eye disease, and I would consider in all the other cases toric lenses in cases of other type of infections. But in the herpetic corneal eye disease is a very difficult case that faces a long history being a young person, and you can really consider that probably the toric lens, especially if astigmatism is moderately high, is going not to be a good choice. You know, nobody has the answer to this question, but it's questionable to use toric lenses when facing an evolving disease, a relapsing disease.
This question is similar to the question about the aspherics. The aspheric IOLs are being put very commonly and without actually looking particularly for the issues, you know. The first question, whether aberrometry is done for all the patients who are undergoing aspheric IOLs. There was a question from the audience that are we looking at the, are we really matching the requirement in all the patients?
You know, corneal aberrometry, the answer is yes, because you have to match the sphericity of the lens negative, you know, to the level to compensate or not the level of corneal sphericity. I don't think that if you are doing advanced intraocular lens surgery today, I'm talking about advanced, you can ignore the corneal sphericity. You have to work with corneal sphericity. And in a given moment, we shall have lenses customized for sphericity. And you have to remember that positive sphericity and negative sphericity both are good for to elongate the depth of focus as far as the patient has metropia, you know. So it is, in my opinion, for advanced indications, you need corneal aberrometry, not for the regular ones.
I think this becomes particularly relevant when it's a post-refractive surgery scenario. You know, most often in virgin corneas is about plus 0.20 to 2.5, so you can go ahead with your conventional lenses. But if it's post-myopic refractive surgery, most often these cases are have a very high asphericity. So putting in the maximum asphericity that's available, usually it's a Technis 1, that's a good idea. But on the other hand, if it is a hyperopia that's been treated, it's a hypoprolate cornea. In these cases, putting a non-aspheric lens, but also even something like a sensor, which is has a positive asphericity, is a good idea. So I think I would be more concerned about the asphericity when it's a post-refractive surgery scenario. But in even in normalized, if it's possible to get this data and tailor-make your lens, it's a good idea. But again, we are not clear whether we should completely neutralize the asphericity on the anterior surface of the cornea, leave behind some amount of asphericity uncorrected. So this is a slightly controversial subject.
Yeah, but you know, this is an important topic because I don't know in India, but we still have in Europe quite a few RK cases, patients with radial keratotomy with a very large amount of spherical aberration positive. What the magic number is 0.25, either negative or positive. The target is to leave the patient in the post-op around 0.25 positive or negative, doesn't matter. And with this, you have to play with a spherical lens or with negative sphericity lens. And that depends completely on the corneal sphericity. More than 0.25, the quality of the retinal image decreases significantly. But up to 25, you might have a patient with an old case of RK in which you can just implant a neutral lens or even a positive lens, increasing somehow the positive sphericity to gain near vision. And these patients are very happy afterwards. So this is quite tricky, and in my opinion, has not been properly addressed so far in the literature. But you have to play with the number. This number was made was demonstrated by the studies of Susana Marcos, who published a very interesting paper in the optical bench, in which all this concept has been totally displayed, and it's a clear, and I use it a lot, and with very good results.
Thank you.
Last word from Dr. Armia. Would you like to add anything, Dr. Armia?
Usually, if you are not going to correct the abrasion of the cornea post-refractive surgery, it's better to put a neutral IOL, zero abrasion, not to increase or decrease the already abrated cornea. This is the best if you cannot correct the abrasions.
With that, shall we call it a day? Mamta, Kavita, Bhaskar, any other questions? I'm so thankful to the entire faculty for giving so much of their valuable time. Really thankful to everybody. Thankful to our multimedia team for their support, especially Mr. Mohan, Mr. Tyagarajan. They've really helped us, and Mrs. Gigi Malati. She has helped me in putting across this program, and I'm really thankful to all of you. Professor Alio, Dr. Richard, Dr. Azna, Dr. Ramurthy. Really thankful to all of you for spending so much of your time, and it was really enjoyable. Thank you.
Thank you so
Thank
much.
you.
Thank you very much.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you
Bye-bye.
so much
Thank you.
for a long weekend here, but thanks so much.
Thank you.